We will get started in just a minute. We're just waiting for the registrants to filter in, and once it starts to slow down a little bit, we'll get started in about a minute. Welcome to Preventing Aerosol Transmissible Diseases in Healthcare Settings. My name is Mitchell Rosen, and I'm the Director of the Center for Public Health Workforce Development at the Rutgers School of Public Health and Deputy Director of the New York, New Jersey Education and Research Center, which is one of 18 NIOSH-funded centers across the country. I'm grateful to our co-sponsors of this program. Their logos are listed here on the slide. And I thank each of these organizations and their representatives for your dedication to and advocacy for worker health and safety. First, a few logistical items. If you have any questions, please use the Q&A function of the webinar. Click on the Q&A icon on the Zoom toolbar to submit your questions. We know it won't be possible to answer all the questions, but we will address as many as we can in the time limits we have. We're asking each of you to submit recommendations for what CDC should do and include in its revision of the healthcare infection control guidance. Throughout the webinar, we'll be posting a link for you to submit your recommendations. The QR code is up there and also the link that is there. The chat box is not active for participants to post, but we'll be adding information throughout the webinar, including speaker bios. The webinar is being recorded and will be posted at the same link that was provided for the webinar information, and we'll send that out information also. The objectives of today's webinar are to describe the science that CDC should use to update the isolation precautions and guidance with respect to modes of transmission, specific organisms and how they transmit infection by aerosol inhalation, and risk factors and controls for aerosol transmission. To reflect and consider the perspectives of all stakeholders, and to recommend updates to the current guidelines that incorporate science and evidence for recognizing, evaluating, and minimizing aerosol inhalation transmission in shared spaces. We have a very packed agenda today with experts providing information on many aspects of issues we are addressing. We're grateful for their presentations and look forward to engaging with each of you on this very important topic. I now turn the podium over to Lisa Brosseau, who will provide additional opening comments.
Thank you, Mitch. I want to extend a big thank you to Mitch Rosen and the New York, New Jersey Occupational Safety and Health Center for sponsoring this workshop and agreeing to host and organize in less than a month. Thank you to our many co-sponsors for helping us disseminate information about the workshop to their members and networks. And thanks to all of you who joined us today for this workshop on preventing aerosol transmissible diseases in healthcare settings. The massive toll of disease and death during the COVID-19 pandemic has underscored the urgent need for stronger protections for aerosol transmissible diseases in healthcare settings. The CDC is currently updating its healthcare infection control guidelines through the Healthcare Infection Control and Prevention Advisory Committee, HICPAC. You'll hear us call it HICPAC throughout this workshop. We developed this workshop to review the current 2007 CDC guideline for isolation precautions, explain the science that HICPAC and CDC should be considering, and to hear from healthcare workers and patients and their advocates on the importance of strong infection control measures in healthcare settings. We will use the outcomes of this workshop to develop recommendations that we will share with HICPAC and CDC on updates they should be making to their healthcare guidelines. We've got great speakers joining us to share their knowledge and experience, and we want all of you to participate by asking questions and sharing your recommendations for what should be in the new CDC guidelines. We've got a lot to cover in a packed program, so let's get started. So our first speaker today is Dr. Justin Chan. He will describe the current 2007 CDC guideline for isolation precautions.
Thank you. Lisa, are you able to see my screen?
Yes, and I can hear you.
Okay, great. Welcome, everyone. Thank you for the organizers for allowing me to speak. I'm going to talk to you for about 10 minutes on the current CDC guidelines that were first disseminated in 2007 regarding isolation precautions. This is really setting the baseline for further discussion. As many of you will note, updated evidence warrants changes to some of the aspects to this set of guidelines. So these are some of the areas that I'll touch upon in my remarks. I'm going to start with a set of practices that the CDC calls core infection prevention and control practices for safe healthcare delivery in all settings. These are really important because a lot of these measures will stand the test of time and continue to be applicable going forward. These represent fundamental standards of care to implement infection prevention and control in all settings where healthcare is delivered, not just hospitals, but outpatient clinics, homes, pharmacies, and other places where healthcare is delivered. All healthcare personnel who have potential for direct or indirect exposure to patients should follow these practices. And before delving into specifics, it's really important to understand the groundwork that has to be in place to make these measures effective. Healthcare facilities need strong leadership support, along with accountability and sufficient resources to implement these core measures. We need strategies for educating healthcare personnel, but also patients and families, because they are important factors for infection prevention and control. And finally, we need to emphasize performance measures and feedback both to leadership and frontline staff on how they're doing. I'm going to move on to standard precautions. This is another core measure that applies to all patient care in all settings. And this should be implemented regardless of the level of suspicion for any potential or confirmed infectious states. The purpose of standard precautions is both to protect the healthcare personnel from infection and also transmission of infections to other patients. And this is a set of standard precautions that should be implemented across the board. Hand hygiene practices with an emphasis on alcohol-based hand rub, environmental cleaning and disinfection using EPA-approved disinfectant products, robust injection and medication safety that emphasizes aseptic technique and practices, and then use of appropriate PPE based on the activities that you are performing. So for example, if you do anticipate direct contact with any bodily fluids or splashes, you should really be wearing gown, gloves, and a face shield. Next is minimizing potential exposures, and there are various strategies for this, including implementing point of entry screening to identify potentially infectious individuals, and really emphasizing standard respiratory hygiene and cough etiquette, including covering nose and mouth if there are respiratory symptoms, and potentially using masking. And then lastly, there's reprocessing of reusable medical equipment, which depends on the intended use of the equipment and the intensity of reprocessing from disinfection all the way to sterilization. There are situations where there is a substantial risk of transmission despite adherence to standard precautions. And this is where the concept of transmission-based precautions apply. And these are recommended for certain patients with suspected or confirmed diagnoses that pose a higher risk of transmission. These measures should be implemented as soon as there is a suspected diagnosis, and then they can be discontinued if that has been ruled out. Communication is important for patients who have transmission-based precautions implemented during transitions of care to different teams or facilities. These have to be communicated clearly. To better understand the rationale for transmission-based precautions, I remind people about the chain of infection. And this is applicable for and is different for the given pathogen, and describes how pathogens go from reservoirs to portals of exit and entry into a susceptible host. If we can understand this chain and break the chain at any point, then transmission will be interrupted. To simplify things, CDC really emphasizes three areas of promoting transmission in healthcare settings. We need to understand the source or reservoir of infectious agents. These could be patients, healthcare staff, or material. We need to understand who is susceptible to acquiring an infection. These are potentially modifiable by vaccination or PPE use. And then lastly, understanding for the pathogen of concern, what is the primary potential modes of transmission. So breaking any of these areas will help us interrupt transmission. So in the 2007 guidelines, the CDC broke down three primary modes of transmission, and I've shown some of the classic examples of these. Contact transmission is through direct or indirect contact with patient bodily fluids or materials, fomites that might be contaminated. In pathogens that transmit via droplets, that's usually by larger respiratory secretions that have to travel through the air and land directly on mucous membranes or conjunctiva. That's sort of an extension of contact transmission, but over a short range. And then the third category is airborne, where smaller respiratory particles can remain suspended for prolonged duration and travel longer distance for transmission. So they have a a schema of recommendations depending on the pathogen of concern for how we should be placing patients, either in single rooms or if necessary for contact and droplet precautions. There can be multi-patient rooms with a certain degree of separation. For pathogens primarily transmitted via the airborne route, an airborne infection isolation room is necessary, which has specifications for negative pressurization and minimum ventilation requirements. And then the key parts of the PPE associated with contact, droplet, and airborne are listed here, with gown and gloves being key to prevent contact transmission, at least a medical mask and to protect against droplet transmission. And finally, airborne routes require an N95 or higher level respirator. So we often, as frontline clinicians, may not know what a patient has in terms of a confirmed diagnosis. So in implementing transmission-based precautions, we have to recognize clinical syndromes that may be associated with pathogens that require transmission-based precautions. And these are just a short list of some of the examples that the CDC provides. For example, a patient who presents with rash or exanthems that are generalized of unknown etiology with a vesicular nature, we have to think of things like varicella zoster virus potentially as the cause, and empirically implement airborne plus contact precautions. And there's various examples of these that we need to think about as frontline clinicians. So it's important to know that the concept of droplet versus airborne is really not dichotomous, and subsequent speakers will get into this. But updated understanding of the science shows that many respiratory viruses can be transmitted longer distance through respiratory aerosols. But what are these aerosols and droplets? So it's really a spectrum of size of respiratory secretions, where larger size secretions generally fall within a meter of the source and don't remain suspended. But the smaller the size, the longer that particle remains suspended in the air and can potentially travel longer distances. So related to this, I do want to say a word about aerosol generating procedures. This is a complicated concept which is fraught with controversy. It's a bit of a misnomer because some of these procedures, there are other activities that can actually generate more aerosols than some of these procedures. But the concept that was described in the 2007 guidelines are that there are certain medical procedures that are prone to generating small particle aerosols. And this is a list of some of the examples that the CDC has provided. This is definitely not a complete list, and there is no definitive list. But the mechanism behind this is that transmission during these situations is increased due to forced air over moist respiratory mucosa. Patients who have a lot of symptoms or disease severity, being close proximity to patients, and prolonged duration. These are situations that increase the risk of transmission. And the minimum precautions for PPE should be at least eye protection, masking, and gown gloves. However, if you cannot exclude the possibility of airborne transmissible pathogens, an N95 respirator really should be used. And that is what we recommend in our facilities. Lastly, I do want to say a word about occupational health, because there is a big interplay between infection control and occupational health. These are some of the key recommendations from the CDC. First, to ensure that healthcare personnel receive recommended immunizations against vaccine-preventable diseases. We should all implement sick leave policies that can avoid staff showing up to work if they're potentially ill. And then lastly, there are various OSHA policies meant to protect healthcare workers against infectious agents. And they're listed here, including bloodborne pathogen standards, respiratory protection standards, and the TB compliance directive. I'll hand it back over to Lisa for the next speaker.
Thank you very much, Justin. We will not be taking any questions at this time. There will be a Q&A session a little bit later in which we'll be taking questions from the audience, which you can put in the Q&A. Our next speaker, Jane Thomason, will describe what we know about HCPAC's plans for updating the isolation precaution guidelines. Thank you, Jane.
Thanks so much. Okay. You should be able to see my slides at this point. Okay,
yeah.
So great. Hi, everyone. Like Lisa said, my name is Jane Thomason. I'm a certified industrial hygienist for National Nurses United. NNU is the largest labor union and professional association for registered nurses in the US. And I have been following the CDC's process to update the isolation precautions guidance that Dr. Jan just shared with us for over a year. Once it became clear that the CDC was planning to weaken guidance, NNU started sounding the alarm. And so in the next 10 minutes, I'll discuss briefly what we have learned about the CDC and HCPAC's proposed updates and their process to make those updates. So a little bit about HCPAC. This is the Healthcare Infection Control Practices Advisory Committee to the CDC. HCPAC is comprised of 8 members with expertise in infection prevention. All of the current members are affiliated with healthcare corporations and universities. They're appointed by the CDC. There are 5 ex officio members from other HHS agencies and 23 liaisons, primarily representing healthcare corporations and professional associations. None of the current liaisons represent healthcare workers or their unions. And thanks to Mitch for dropping the link to the HCPAC roster in the chat. So HCPAC's process to update the 2007 isolation precautions guidance begins with a work group. The isolation precautions work group is composed of both HCPAC members and additional individuals from the infection prevention field, and they have extensive CDC staff support. They began meeting in February of 2022, and the work group meetings are closed to the public. The only access we have to their work is from presentations that they give to full HCPAC membership at public meetings. The work group's June 2023 presentation provided us details about their proposals. HCPAC was originally slated to vote on these proposals at their August meeting, which they then delayed until November because of our advocacy. CDC has posted the June work group presentation on their website, and I'll post the link in the chat here. Thanks, Mitch. Please note that this is a new practice that has changed because of our advocacy. Up until this point, the only way to get a presentation was to have actually attended the meeting. So that's another thing that has changed. Okay. We also now have additional information about the work group's efforts. Earlier this year, NNU submitted official requests under FACA and FOIA, 2 different statutes, for work group materials. The CDC initially rejected our requests, but after receiving public pressure, HCPAC shared meeting summaries for the isolation precautions work group from February 2022 through May 2023. NNU has reviewed these meeting summaries on our website and posted them on our website so that the public can review them. We'll make sure the link is in the chat. The content of the meeting summaries really confirms a lot of the concerns that we had about HCPAC and the CDC's orientation. Just to highlight a couple of those concerns, one is that the work group has consistently prioritized employer costs and profits under the umbrella of feasibility and flexibility over robust protections for workers and patients. The work group has sought for updated guidance to provide a basement recommendation upon which employers are then intended to build their infection control programs based on employers' own assessment of things like staffing levels, healthcare worker vaccination status, and patient immunocompromised status. And we saw how this approach worked during COVID with the CDC's crisis and contingency standards. Healthcare employers removed protections, literally locking up N95s and refusing to grant workers access, even while they were caring for COVID positive patients. And then those employers turned around and said they were just following CDC guidance. And now the CDC and HICPAC are trying to adopt that approach for all of infection control. Another thing that we learned is that the work group has maintained a consistent and explicit orientation towards recommending fewer precautions than are currently employed, including for ventilation, respirators, gowns, and gloves. And from the beginning of the process, the work group has intended to rely on their own expert opinion where scientific evidence is lacking, despite the fact that the committee has very narrow expertise represented and is missing some essential perspectives. In June, we learned more details about HICPAC's draft proposals to update their infection control guidance. We learned that the work group is proposing 2 new categories of transmission, by air and by touch, to replace the current faulty droplet airborne contact paradigm. And while this may seem like a step in the right direction, the work group's description of transmission by air actually fails to fully recognize the science on aerosol transmission. HICPAC remains focused on distance as the primary determinant of transmission of infectious diseases through the air. HICPAC's work group is failing to recognize the role that inhalation plays in aerosol transmission and the impact of other factors, such as time, dose, activity, and environmental factors. We'll hear a little bit more about that science from later speakers. In June, we also saw the results of an evidence review that the work group solicited from CDC staff to evaluate the effectiveness of N95 respirators. The CDC's evidence review is biased and incomplete and concluded that N95s were no different than surgical masks in protecting healthcare workers from respiratory viral illnesses. Issues with the CDC's evidence review included that they cherry-picked data from studies, ignoring data points where N95s were found to be more effective than surgical masks. They excluded one essential randomized control trial with zero explanation for why. In fact, their selection and exclusion criteria have not been publicly shared. They excluded an extensive body of research that has found that N95s are effective at protecting workers from inhalation of hazardous aerosols. And they also included studies that were flawed. Some of these studies failed to evaluate whether respirators were used in the context of an OSHA-compliant respiratory protection program. The CDC has said in multiple places that they are focused on, quote, real-world evidence in how they are evaluating N95 respirators and other protections in this process to make updates. But the reality of what that means is that they are willfully failing to account for employer practices that actually undermine N95 protection. They are failing to account for practices like reuse, extended use, and lack of or inadequate fit testing and training. And instead, they're concluding that it's the N95 respirators that don't work, instead of the fact that employers aren't implementing a full and OSHA-compliant respiratory protection program. It's clear in the work group meeting summaries that members started out this process to make updates with a goal of using N95s in fewer situations. Okay, so here's where the rubber actually meets the road, though. The work group's proposals for protections for healthcare workers exposed to infectious diseases that are transmitted through the air. The work group is proposing 3 tiers of precautions within the by air category. If we can start at the bottom of the table, extended air precautions, they are saying would apply to pathogens like tuberculosis, measles, and varicella. This preserves the current disproven airborne droplet dichotomy. Novel air precautions would apply to MERS, SARS-1, and pandemic phase respiratory viruses like influenza and SARS-CoV-2. And they're saying an N95 would be used, but no airborne infection isolation rooms. This is a step down from current practice. Novel pathogens need an airborne infection isolation room because we don't know yet how they transmit. And then this third category, routine air precautions, they're saying would apply to pathogens like seasonal coronavirus and seasonal influenza. So what's happening here is the CDC is recognizing that these pathogens transmit through the air, but then they're turning around and saying a medical surgical face mask is enough to protect healthcare workers, even though those types of masks do not protect against inhalation of hazardous aerosols. This distinction between pandemic and seasonal phase for the same pathogen sets the CDC up to downgrade protections for COVID from an N95 to a surgical mask. The bottom line here is that HICPAC is proposing to update these precautions in name only, but when it comes to worker protections, they're not only refusing to recognize updated science, but they're actually moving backwards. It's also important to note that the June proposals did not include any mention of ventilation, patient screening and isolation, staffing, or other major elements of infection control. This is concerning given the work group's explicit goal is to have minimal standards in the updated guidance and to leave as much as possible up to individual employers. Okay, so here's an outline of CDC and HCPAC's process, how they are creating these updates, and where public input is being solicited by the CDC. The short version is that this process is largely happening behind closed doors. And this diagram is taken from the CDC's website and adapted. So step one, they establish a work group. There's no public access or input, multiple requests for HCPAC and CDC to engage a broader range of experts outside of infection control, like aerosol scientists, respiratory protection experts, ventilation engineers. Many of the folks that we'll hear from in this webinar today have been rejected. And our requests for stakeholders, including healthcare workers, unions, and patients, have also been rejected. And step two, the work group presents their proposals to the full HCPAC membership for review and discussion. At these HCPAC meetings, the public is allowed 3-minute comments. But at the August meeting, public comments were actually cut off after just 14 speakers, leaving many people unheard. Written comment is allowed, but they're not actually made available ahead of the next meeting. Step three, the draft is voted on by HCPAC and sent to CDC. This vote is currently slated for the next meeting, which is scheduled for November 2nd and 3rd. But the draft itself has not yet been publicly released, even though the meeting is approaching rapidly. In past meetings, HCPAC members actually voted before hearing public comment, although I'll note that this was changed at the August meeting due to our public pressure. The lack of a draft severely limits the public's ability to effectively engage in this process. And then steps 4 through 6, you'll see the CDC reviews the draft, they post it in the Federal Register for public comment, and then the draft is sent back to HCPAC for finalization. And the CDC has been encouraging us to actually wait for this process, this point in the process for the Federal Register posting to engage. But by the time it gets there, decisions have already been made and major changes are unlikely to happen. The CDC historically rubber stamps what HCPAC sends them. And so we have been urging engagement with experts outside of infection control and stakeholders before any HCPAC vote. And I'll finish my presentation by saying that you can take action to make sure that the CDC hears from people like you. You can first share your recommendations for what the CDC should include in their updated guidance with us. The link is in the chat box, or you can scan the first QR code on the side. We'll be collecting your recommendations and sending them to the CDC as part of a report on this workshop. This is the kind of public meeting that the CDC should be hosting themselves. You can also join NNU in urging CDC leaders to release the draft and hold public meetings to provide healthcare workers, patients, and other experts the opportunity to provide input before any vote to finalize updates. You can scan the QR code on the slide. There's a link there as well. I can drop it in the chat. And then finally, you can provide comment at the upcoming November 2nd and 3rd HCPAC meetings. You can either provide your comment orally, or you can send it in writing. HCPAC has more directions on their website for how to sign up or submit, and I'll drop that link in the chat as well. Thank you so much. I'll turn it back to Lisa.
Thank you very much, Jane. We have invited some frontline healthcare workers and patient advocates to describe their personal experiences with infection control practices. The first person who's going to talk is Nancy Higgins from the National Nurses United. Nancy.
Good afternoon, all, and thank you for having me here. My name is Nancy Higgins, and I am the president of the National Nurses United, the largest nursing profession for registered nurse in the United States. And I'm also the New York State Nurses Association president. I've been a nurse for over 37 years, and I work in Brooklyn at Maimonides Medical Center, which was an epicenter of the COVID pandemic. At one point, every unit in our hospital was a COVID unit. When the COVID pandemic began, my hospital, like so many others, was unprepared. We had to fight for PPE, and that we really needed to care for our patients safely. Our hospital claimed the virus was spread through droplet transmission, and that all we needed for protection were surgical masks. So as nurses, we stood up and demanded safer PPE. We insisted on N95 respirators as the minimum based on the precautionary principle. We called for more protective respirators like poppers and elastomeric. We held collective actions. We went to the media, circulated petition, filed OSHA complaint, and called on Congress to support us. As we fought to protect our patient, we saw the CDC weakens its guidance to create flexibility from our employers. Many employers had N95 respirators in storage, but refused to give nurses access, even though we were caring for non-COVID patients. Our employers told nurses to reuse the same N95 shift after shift or to clean it with bleach, even though N95 were designed for single use only. Our employers forced us to return to work, even when we were COVID positive, all because the CDC's guidance gave the flexibility to do so. We confronted our employers about these unsafe practices, but our employers maintained that they were following CDC guidelines. This led to countless infections among healthcare workers and patients that could have been prevented. I have a coworker who got COVID at work. She brought the virus home to a 92-year-old mother, and her mother died. My coworker was so bereft, she wanted to commit suicide. We had to get her help. She ended up quitting the nursing profession entirely because in her heart, she caused her mother to die. But really, the reality is that our employer failed to protect her, and the CDC's weak guidance is at fault. Our employers talk about needing flexibility to respond to the nursing shortage, but really, there are over 1 million nurses currently who are not working as nurses in the United States because of the poor working condition. Nurses are leaving the bedside in high numbers because of the abandonment of our health and safety during the COVID pandemic. As nurses, we need to work to save the world. We put our patients and our community ahead of us, but the CDC is putting us behind again. With this rollback, the CDC is proposing to literally take away our livelihood. The CDC is being reckless with people's lives. Thank you.
Thank you very much, Nancy. Our next speaker is Farheen Malik, who's a member of the People's CDC. Farheen, go ahead.
Hi all, thank you for having me here. As Lisa mentioned, my name is Farheen and I'm a designer at Google in New York and a member of the People's CDC. I have multiple chronic illnesses, which put me at high risk for severe outcomes from COVID-19 or other infections. I'm here today to share my personal experiences as a patient in healthcare and to provide input on what I think the CDC should include in their updates to isolation precaution guidelines. So before the pandemic, most of my challenges with healthcare were related to finding providers who would take me seriously, as well as dealing with lots of admin. I don't remember feeling unsafe in the same way that I do now, and that's including when I was hospitalized with EPV. Earlier in the pandemic, I had a few procedures and a surgery where I remember universal masking, testing, and other layers of protection, and much less of the need to advocate for safe access to those interventions. But as the pandemic has worn on, it has become increasingly difficult to find healthcare facilities that are visibly conscious of the role they might play in spreading respiratory viruses. This is despite the fact that those facilities have the same providers who have warned me not to get COVID because it would make my life a lot harder. Specifically, since the lifting of mask mandates, it feels like infection control has gone backwards. I have to advocate for myself more than ever before. And when providers are able to find a mask after I ask them to put it on, it's usually a surgical mask and it often comes out of their pocket crumpled or from some nearby table. As a result of this difficulty, I've had to delay or cancel important medical appointments, including a surgery and a procedure, and this has delayed diagnoses. One specifically is still unresolved because of difficulty finding a facility who will do the procedure while also protecting me from becoming additionally ill. But meanwhile, I've lost weight, had to manage anemia because whatever is going on seems to be malnourishing me. The procedure is finally coming up, and I'm still concerned that while the hospital has agreed to my reasonable accommodation requests after many calls and emails, they won't actually follow all of them in real time. In summary, given my exposure to healthcare settings, I and others like me are frequently at risk. Uncertainty in infection control measures intensifies this risk, turning the very places that should offer healing into potential sources of danger. The CDC's updated guidelines for isolation precautions should recognize the significant role of aerosol transmission in disease spread. A protective approach should include exposure assessments, written exposure control plans, precise control measures like proper ventilation, airborne isolation rooms, and PPE, including universal masking with broad use of well-fitting N95s or better. Prioritizing a clear approach to protect individuals like me, healthcare workers, and all patients really is paramount. Our health and our lives depend on it. Thank you.
Thank you very much, Raheen. Finally, we have Kristen Urquiza, who's a co-founder of Marked by COVID.
Thank you, Lisa. And hello, everyone. I'm Kristen Urquiza from Marked by COVID. We are the nation's largest network of COVID grievers, working for pandemic justice, remembrance, workplace safety, and health equity. I want to start by putting the pandemic's scale into perspective. In just its first 2 years alone, COVID claimed more than 1 million lives in the United States. In comparison, 40 years of AIDS and HIV resulted in 700,000 US lives lost. This startling disparity emphasizes our pressing duty to prevent additional losses and to stave off the normalization of mass death and disability that's acceptable. Let me be clear, it is absolutely not. Today, I'm speaking on behalf of more than 10 million estimated US COVID grievers advocating for decisive action to bolster guidelines that prevent aerosol transmissible diseases in healthcare environments. The loss of my own father, Mark Urquiza, to COVID stands as a poignant testament to the consequences of insufficient protective measures. He was otherwise a healthy 65-year-old man whose trust in the leadership of this country ultimately cost him his life. And while my father's story resonates with millions as it echoes the pain and anguish of the nation in the early days of the COVID crisis, we're still in a crisis. We're bucking safety precautions and abandoning data collection in this bizarre, anti-science, and inhumane effort to find normal at any cost. I'm not here to share with you the mountain of evidence as to why keeping high-quality masking in healthcare settings is the right thing to do. My colleagues who are doctors and public health professional colleagues are here to do that for you. Instead, I'm here to share with you the consequences of our actions or inactions. Simply put, hospitals are no longer safe. Today's families marked by COVID are overwhelmingly individuals who are mourning the death of a loved one that caught an aerosol transmissible disease in a healthcare environment. They have a loved one who goes in for procedure X to exit in a body bag because of Y. Once sanctuaries of health and healing, hospitals and healthcare settings now pose threats to our most vulnerable and the workers who go there every single day. It is our moral duty to act to prevent further avoidable deaths. And yes, I'm angry. I know many of you are angry as well. I cannot believe that 3.5 years later, I'm asking the same thing of our elected officials and agencies entrusted with our health to follow the science, to be transparent with the process, and engage with experts in the field and those of us with lived experience. And this time, I'm not doing it because my dad died. I'm doing it because I want to save my mother and others who I know are vulnerable. While she survived COVID, my father did not. She was not unscathed. Since then, she's been battling long COVID and her health continues to be in decline. She recently learned that she needs surgery and she might also have cancer. And my predominant fear is not the procedure nor cancer, but her potential exposure to COVID while in a hospital setting. Her existing struggle with long COVID has been debilitating, and any additional setback, especially at her young age of 69, feels insurmountable for our working class family. The anguish of potentially losing my only other parent, especially when prevention is within our reach, is overwhelming. I will continue to share my story to shed light on the gravity of this situation. And while it is tragic, it is not unique. Countless people in this country share a story like mine, and this broader collective experience, especially in the richest nation in the world with the most advances in medical science, underscores the urgent need for rigorous protective guidelines, including masking in healthcare settings. So on that note, I implore the CDC and HCPAC to heed our experiences, respect the science, and truly recognize the lasting toll of these diseases. We must reinstate these places as safe havens, ensuring that an additional life is not needlessly lost. The cost, as I have been forced to experience and witness again and again, is far too great.
Kristen. Thank you very much, Kristen. Okay, our next speaker is Don Milton. He will discuss the science of aerosol transmission of communicable respiratory pathogens. Go ahead, Don.
Can you see my screen, my slides?
Yes, and I can hear you. Thank you.
So respiratory viruses and some bacteria are transmitted via certain modes, primarily inhalation of fine particle aerosols that range from very large particles that deposit primarily in the nose and mouth, to those that enter the chest that are somewhat smaller, and finally very small aerosol particles that can penetrate deep into the lung. And there was a lot of misunderstanding early in the pandemic. Traditionally, medical people have thought about only these very small aerosols and misunderstood how they behave. Spray and touch are other modes of transmission. Primarily, probably touch is important. The spray of ballistic droplets is probably a relatively minor mode of transmission. But one of the things that's really important to understand is that the cloud of fine aerosol particles is most concentrated close to the source, and not only something that happens far away on rare occasions, but rather dominates what's happening close to the source. This has been a misunderstanding again, with often thinking that anything that happens close to the source must be spray driven. But we now understand that, in fact, it's primarily aerosol inhalation that's happening close to the source, or touch. And the other thing that's really important to understand about transmission of these infections, influenza and SARS-CoV-2, is that only a small fraction of people are symptomatic. And this is from a paper almost 10 years ago in the UK, looking at people without influenza vaccine in a medical practice and showing that indeed, the vast majority of people who become infected have no evidence of symptoms, but they develop antibodies showing that they've been infected. And it's only the tip of the iceberg who are actually medically attended cases. And yet all of these people are potentially contagious. And this has been a huge problem during COVID, because we understand now that asymptomatic people can be contagious. This should have been evident very early in the pandemic, because back in January from Wuhan, there was a family that traveled and had symptomatic COVID among the adults, but a 10-year-old who was asymptomatic had ground glass opacities in the lung and was cruelly infected. And those ground glass capacities suggest that he had infection where aerosols are generated from the lung. So just focusing on the acute infections is not going to be effective because we don't know who all the people are who might be contagious. Source control must be directed towards everyone in the workplace, healthcare in particular. So we've been studying in my lab for many years how people generate aerosols of infectious agents. And we study them with this by asking people with influenza and COVID to come sit in a booth where we sample the air around their head as they breathe, cough spontaneously, talk, sing, yell, and so forth. In our flu studies, we just had people cough spontaneously and recite the alphabet a few times. And yet we found that even with no coughing, people were shedding significant amounts of viral RNA into the air, and that we were able to culture virus from these people. And you see in half an hour, these people were shedding up to hundreds of thousands of viral particles into the air. We've also looked in these studies at masks and respirators as source control. And in the earliest study published 10 years ago, we showed that putting a surgical mask on people with influenza reduced the amount of virus that they were shedding into the larger particles that float in the air. It pretty much eliminated them except for a few cases. For the finer particles, it cut them down in about in half. But the other thing to notice here is that even among the people with no masks, that the amount of virus in fine particle aerosols that float in the air and can penetrate deep in the lung are more than those in the coarser particles that will not travel very far. NIOSH, CDC, has done some nice studies looking at the effect of masks using this laboratory system with mannequins. And they have shown that ear loop surgical masks like these have some impact, and that as you tighten up the fit on these masks, they work better. And that as you have more people in the environment masks, they work better as well. If you just put the mask on the source and it's a surgical mask or a cloth mask over a surgical mask or a knotted mask, as you get the fit better, they get better. If you put a mask on the recipient, it also has some effect. And if everybody is masked, it does even better. And this is now using, even in this case, medical masks and knotted and cloth masks. It's not using N95s. We then extended this work to look at N95s. We had, during the pandemic here as a timeline, studied cloth masks and surgical masks and KN95s. And later during Omicron, we studied N95s. Again, with this same apparatus, having people would give us a sample with their mask on and then without a mask. And what we see is shown here. This is going to the left is better. This is here how much they were shedding with no mask. This is here 10% still getting through, and here is 1% getting through. And you can see that N95s vastly outperformed all other masks And interestingly, cloth masks, when people made their own cloth masks and they wrap well around their face and fit fairly tightly, actually outperformed surgical masks and KN95s, and quite statistically significantly. But if you looked at the percent improvement of N95s over the others, N95s had a 93% improvement over what was accomplished by surgical masks and a 94% improvement over KN95s, albeit our KN95s were very stiff and didn't fit very many people well. So when you think about what to do, you have to have a risk assessment and control banding as critical tools to decide where you should put your controls. And there are a number of factors that have to be taken into account. The prevalence of respiratory infections in the community, how active is COVID, how active is flu, how pathogenic are the infections that are going around, how much morbidity and mortality is there, can source controls be implemented? It's very rare that cases are distinct and symptomatic enough to be able to use only very directed source control. Can pathway controls be implemented? Can receptor controls be implemented? And what is the availability of medical countermeasures? Pathway controls have to be the first level of things, because ventilation, filtration, air disinfection are things that can be operational all the time before you know you have a problem. They're passive and always active, and they can always be upgraded with increasing risk. Source and receptor controls both require behavioral interventions and are difficult to implement sometimes. And source and receptor controls can be added as the risk increases. Thank you for your attention.
John, thank you very, very much. I know you're under a tight time schedule, so I really appreciate your participating today. For the next 15, almost 20 minutes, we're going to try and end the next session at about 12:15, so we can keep back on schedule. I'll introduce Dr. Kate McFall, who's going to lead a Q&A session with our presenters. And also joining this panel is Dr. Amber Mitchell. So please put any questions you have for the panel in the Q&A. I know you've been doing that throughout, and we do have some monitors who are keeping track. We want to try and answer as many as possible, so please keep your questions short. Thank you, Kate.
Thank you, Lisa, and thank you to the speakers and stakeholders especially for taking the time to come to this webinar and provide us with your insights. So now let's engage with the audience and our panelists around incorporating the current science into the CDC guidelines. I'm going to ask the panelists to keep your answers relatively brief because we have a lot of questions. We want to get to as many as we can from the audience. And I want to say to the audience, we are definitely doing our best to get to as many questions as we can. And there are a number of ways that you can provide input, which are being reviewed as we go along. I'd like to start with Amber. And ask you, how do healthcare facilities and patient care providers reconcile complying with the OSHA regulations, like the respiratory protection and bloodborne pathogen standards, as well as the CDC HICPAC guidelines? And we do have a number of questions around this issue. More simply asked, how do the various agencies rank in terms of the CDC guidelines?
Thanks, Kate. It's a really important question, and I just want to start by saying the statements I'm about to make are my opinions based on my experience in doing occupational infection prevention for my entire career. So yeah, it's really difficult to be an OSHA compliance or enforcement officer. I've been bullied by healthcare facilities over the years that CDC takes precedent over OSHA. And while OSHA requires hand washing with soap and running water, higher degree of respiratory protection, focus on risk assessment and training, but I will note that CDC focused interventions like patient and source masking, rapid diagnostic testing, reprocessing of medical equipment also protect the worker at the bedside, giving healthcare workers a little more information and safeguards about how patient safety protects them. One other thing is that while Department of Labor manages oversight for sick leave and pay, OSHA does not. So they have to rely on Department of Labor, other agencies, and CDC does have the leeway to address those in its recommendations. So not just addressing occupational hazards to ATDs, but the nuts and bolts of managing staff. Last point I'm going to make is that a lot of people say 5A1 citations or citations from the general duty clause are a great way for OSHA to enforce CDC guidance. But I did some research just this morning. In the last year, so the last 12 months, there were only 12 general duty clause citations issued in all of healthcare in all states, and only 33 in the last 5 years. So I'm hoping that just in identifying which agency has purview over which element, we can really help to build these bridges between the two agencies and incorporate a lot more of CDC's sister agency, which is NIOSH, especially on respiratory protection.
Thank you, Amber. Thank you very much. And the next question is for Justin. Can you talk about how you think worker health and safety interacts with patient safety and how the CDC guidelines could better incorporate both of these?
Sure. Yeah, there's definitely a close interplay between patient safety and occupational health. And I think specifically when it comes to respiratory viruses, we do see increased healthcare worker illness during respiratory virus season. And we do see increased onset of respiratory viruses that are diagnosed in patients while they're in the hospital. So we are definitely concerned that when there are respiratory viruses circulating, that people do bring illness to work. While we have sick leave policies that ask workers to stay home when they're sick, there is still a culture and pressure to show up to work and to put in your shifts so that you don't end up burdening your coworkers. And while we discourage that, we do have to consider the human behavior and culture in our society. So with all that in mind, along with the fact that there is a lot of asymptomatic infection that is transmissible, we do need to think very carefully about universal masking policies in healthcare settings. And there's been a lot discussed back and forth in the literature about the benefits and drawbacks of this. But I think CDC and HICPAC, it would be helpful to come down with better guidance on when and if universal masking should be implemented in the healthcare setting, especially during times of high community transmission.
Thank you. Thank you very much. The next question I have is probably best for Nancy. Nancy, how important is the prevention of healthcare worker infection and disease in limiting patient infection? This is a two-part question. And then what are the implications of what HICPAC has proposed on worker and patient safety?
Well, as you know, it's very important that, we nurses are protected, because when we come to work, if we are not protected, we cannot protect our patients. And with that being said, it seems that the CDC is really putting profit over patients, because what they've been doing is pretty much listening to the, to the employers, because the employers have donated a lot of money toward them. So we feel that the HIPAC members are exclusively representing the healthcare corporation. We've seen the CDC prioritize employers' cost consideration over the workers, patient health throughout the COVID pandemic. For example, in mid-2020, when it was downgraded by the guidance to allow the hospital to provide nurses with surgical masks instead of N95 for COVID after lobbying by the industry. NNU has led the campaign to get CDC and HIPAC to open up the process, to update the infectious control guidance, input from direct healthcare workers in our union. It is essential to crafting robust protective guidance. It is essential that for CDC and HIPAC to engage in the input of direct care nurses or the healthcare workers in our union. We are the one who work on the front line. We are the one who actually implement the infectious control protocol to protect our patients and ourselves. We have essential insight about the implementation. So we need stronger guidance, and we need to make sure that our employers are clearly required to implement strong protection, not giving extensive flexibility to prioritize profit over patient care, over safe patient care.
Thank you. Thank you for that. We do have a question asking Dr. Milton to clarify one of his slides, which I should be able to do. Basically, I work with him and we put the slides together. And the question is that we need to clarify that his last couple of slides, when he was comparing N95s to surgical masks, cloth masks, and KN95s, was from the standpoint of source control. So he measures exhaled breath when the participant has the mask on. So he's actually measuring what comes out when the mask is on the face. So that was for source control, not for PPE at that point. We have a couple of questions here that I think are best for Jane. The questions have to do with the ways that we can basically work with CDC, push back, participate, engage. One of the first questions is to clarify about CDC's guidelines being recommended practices and not law.
That's a really important question. Thanks for asking that. So the questioner is correct. The CDC does not actually have an enforcement power. All they do is make guidance. That being said, the CDC is often treated as the gold standard. It looks like I might have frozen for a second. Did you catch my answer?
Yes.
I did.
Okay.
Yeah, I can still hear
great.
you.
Just wanted to double check. The CDC guidance is treated as what everyone does. The isolation precautions guidance is often referred to as the Bible in infection control, and other agencies incorporate CDC's guidance by reference. OSHA has a history of incorporating CDC's guidance by reference. CMS incorporates CDC's guidance by reference. There are state agencies that do that as well. So I think it's, while the CDC itself doesn't have enforcement powers, it's really important to recognize the broad-ranging impacts of what the CDC puts together here.
Thank you. I don't know, Amber, if you wanted to add to that as well, or have anything else to add?
I will. It actually touches on the point that I made at the very outset, which is I've been bullied out of healthcare facilities that have said CDC takes purview, and I do occupational infection prevention for a living. So it gets very difficult, and I'm sure those of you that are in healthcare facilities see it too, with this dichotomy of power between industrial hygiene, or EH&S, and infection prevention and control. I think it's time to just blast through all of this long-term animosity that the two professions have had for each other and really figure out how to build these bridges. Because the last thing we want is for the worker to become the patient. And in a lot of situations, especially that we've heard with COVID, workers have become patients, and it gets very difficult for them to advocate for themselves, for us to advocate for themselves, for ourselves as patients. So we really need to go back to thinking a lot more holistically about facility safety and all the people that are in that facility, especially in healthcare.
Absolutely. Thank you for adding that on. And this is a somewhat related question. It might be best for Justin. Should the updated guidelines recommend some way that especially vulnerable patients can identify themselves and require that only masked healthcare workers are around them?
Yeah, that brings up a good point that in our healthcare facilities, there are some individuals that are particularly vulnerable and immune compromised. And there are healthcare facilities that have carved out tailored infection control measures, such as continuing to mandate universal masking around immune compromised individuals. And we do that to a certain extent in our health system as well. But I do see a couple of downsides to that, is that number one, it can be hard to universally identify all of our extremely vulnerable patients. And secondly, there can be a challenge of power dynamics in a patient asking or demanding that their healthcare workers mask. I mean, they should, but some people may not feel comfortable with doing that. So I think those factors have to be taken into account whenever we try to carve out specialized measures for certain populations. And one way to get around that is during higher periods of higher risk, just to require masking for direct patient care encounters.
Thank you. I know this came up with respect to really almost everybody, whether it's your loved one that's in the bed or whether it's your coworker or colleague. And there seem to be people that are not, following the guidelines, that a process or maybe something explicit in the guidelines for the best way to do that would help give people kind of permission to say what they need to say. Thank you so much for that. Okay, so we have another a couple of seconds here to add. It seems like we have a lot of questions from the audience wondering more about what they can do, particularly in addition to the information we're passing along about communicating through us and also with the CDC. Should there be more pressure on Congress to get involved, and would that help? Maybe that's a question for Jane or for Nancy or any of the panelists.
Yeah, well, we need to put pressure on the Congress, and then NNU has been doing that, working together to hold CDC accountable, crafting guidance, and then we have launched a new click to your email action where you could fill out a form and send the email to CDC. Leaders included Director Mandy Cohen. The email urges CDC leaders to release the draft with the enter time for public review and hold public meeting and ahead of a vote. So we will put the link in the chat box, or you could go to the NNU website at nationalnursesunited.org.
That's pretty much all the time we have for questions. I greatly appreciate all the questions from the audience and the incredible engagement out there, and especially our panelists who took these questions and gave us such insightful answers. Thank you. Thank you all very much.
Thank you, Kate. Thank you, Kate, Justin, Nancy, Jane, and Amber. That was great. We've invited some additional frontline healthcare workers, patient advocates, and a representative from California OSHA to describe their experiences with infection prevention and control. First to speak is Dr. Andy Bowdle from the University of Washington.
Thank you, Lisa. My name is Andy Bowdle. I'm a cardiac anesthesiologist. Some of my colleagues and I have been wearing N95 respirators throughout our hospital since March of 2020, and we continue to do so today. We have also been using portable HEPA-rated air purifiers in our offices during the same time period. During much of the COVID-19 pandemic, our respiratory precautions were not in agreement with the policies of our institution and are not in agreement with the current policies of our institution. However, we were convinced that the risks of aerosol transmission from the beginning of the COVID-19 pandemic. I speak today for myself, but also for many of my coworkers. In addition to protecting ourselves, we are very concerned about protecting our patients, many being elderly, immunosuppressed, and with other risk factors. We have seen patients become infected with COVID-19 while hospitalized, and some of those patients have died of COVID-19. We believe that in many instances, these patients were not protected as well as they could have been. We are concerned not only with COVID-19, but with all of the other aerosol transmissible diseases. We believe that during times of substantial prevalence of aerosol transmissible diseases, including the current moment with COVID-19, there should be universal masking in healthcare facilities. And by masking, I specifically mean respirators, such as N95, whenever possible. We believe that we have an obligation to patients to protect them to the best of our ability and also to our healthcare coworkers. We strongly believe that CDC guidelines for infection prevention should recognize the need for the frequent application of effective respiratory protection during the routine conduct of healthcare, recognizing that aerosol transmissible diseases are frequent and common threats. We strongly support additional research to improve the effectiveness and tolerability of respirators, to include further development of elastomeric respirators for use in healthcare settings. Ever since the HIV epidemic, we have accepted the need for standard blood-borne precautions. Now that we fully appreciate the significance of aerosol transmission of respiratory and other diseases, we need to also accept the need for routine respiratory protection in our healthcare facilities. Thank you.
Thank you very much, Andy. Our next stakeholder speaker is Jennifer Ritz-Sullivan, a patient advocate. Jen?
Hello. As stated, my name is Jennifer Ritz-Sullivan. I am disabled and chronically ill, and I'm fully aware of the devastating impacts of aerosol transmissible viruses, particularly COVID. I lost my 66-year-old disabled mom, early on to COVID in December of 2020. She contracted the virus from a household member who did not wear a mask. My mom died because of someone's decision not to mask. My husband works at a high exposure job and is frequently the only person with a respirator. We caught COVID through one-way masking from his job this spring when cases were considered relatively low. One-way masking, as you've heard, is not safe enough for high-risk folks or for anyone. So despite being up to date on vaccines and having access to Paxlovid and numerous over-the-counter medications, it is the sickest I have ever been, and I remain high risk for the same disease that killed my mom. I haven't fully recovered, and I am now further disabled by long COVID. I did not consent to COVID, and neither did my mother. My healthcare center dropped masking in May. Although there are some medical needs I am able to put off until it's safer, I still require frequent office visits. I requested that my providers wear respirators when meeting with me, even offering to supply them. And I was told that they only need to wear surgical masks if asked by a patient as they go by CDC guidelines. Surgical masks worn by a few providers in a large healthcare facility are insufficient to protect me or anyone from aerosol transmissible diseases. Every visit requires prompting, advocacy, and risk, which all deplete me. With my masking request at the top of my file, I still have to state the request when I book my appointment, when I arrive for it, and when I meet the physician's assistant. I've had providers become rude to me the second I ask them to mask, huffing, rolling their eyes, and only wearing a surgical mask under their nose the entire time, as if they've never worn a mask before. No one should have to risk disability or death to receive medical care. We need increased universal guidelines for the safety of everyone. And we must learn from the dead and disabled, and we must do better. Thank you.
Thank you very much, Jen. Our next speaker is Eric Berg from California OSHA. Eric.
Right, thank you very much. Yeah, my name is Eric Berg. I'm the Deputy Chief of Health for Cal OSHA, and my group is responsible for writing the occupational health regulations for the state of California and the California OSHA program. So going back in February 3rd, 2020, 1 month after the first reports of the COVID outbreak, Cal OSHA issued written guidance for COVID-19. Cal OSHA stated that workers must be protected from COVID-19 through use of airborne infection isolation, NIOSH approved respirators, source controls, specific training, and several other protective measures necessary for airborne infectious diseases. These protections were, back then, and they continue to be today, mandatory for workers exposed to COVID-19 in healthcare, correctional facilities, and many other types of facilities, service categories, and operations. These worker protection requirements are the law in California due to the Aerosol Transmissible Disease Standard, or Title 8, Section 5199, established in 2009, many years ago. This law covers many infectious diseases, including diseases caused by novel pathogens, such as SARS-CoV-2 and unknown pathogens. CDC, unfortunately, and erroneously, did not recognize COVID-19 as airborne in 2020 and issued guidance that was much less protective than California law. This contradiction created confusion that resulted in some workplaces not complying with the California ATD standard, and then, as a result, suffering from deadly outbreaks. Forgotten in these workplaces was the fact that California law prevails over CDC recommendations or any other recommendations that are less protective than the law. Also, disposable respirator shortages occurred in 2020. Cal OSHA and many others urged employers to use respirators specifically designed to be reusable, which were not in shortage at the time. Unfortunately, other entities put into practice the reuse of disposable respirators, which were never designed nor made to be reusable. This resulted in inadequate protection for workers and new hazards for workers. Moving forward to the present, we know from extensive studies by NIOSH and many others that only respirators can protect against fine and ultrafine particles that can carry airborne infectious pathogens. And it's very easy to test how much protection a person gets against airborne particles using a respirator. This is done using quantitative fit testing that has been in OSHA and in Cal OSHA law for many decades. Half-face respirators, such as N95 respirators, when using a quantitative fit test, must achieve a fit factor of at least 100 to pass the test. Studies have shown that surgical masks will provide a fit factor of 2 or maybe 3 in quantitative fit testing. The protection provided by a surgical mask is 33 to 50 times less than that provided by even the most basic respirator when used properly. to state there is no difference in the effectiveness of a surgical medical mask and a NIOSH-approved respirator to prevent transmission of airborne diseases is false, is unacceptable, puts workers in danger, and is not supported by science. Again, California law in the past and in the future will require workers to be protected from airborne infectious agents with airborne infection isolation, NIOSH-approved respirators, source controls, and many other protective measures. This will not change. PICPAC and CDC recommendations, which are less protective and contrary to California law, will serve to create confusion and pretext for some to not adequately protect workers. The scientific community, public health professionals, and health advocates should let CDC know that undermining worker protections with unscientific reasoning is not acceptable. Thank you.
Thank you very much, Eric. Our last speaker in this session is Kimberly Wills O'Connell, a critical care nurse.
Good afternoon, everyone. Again, my name is Kim O'Connell. I have been a critical care nurse for more than 30 years now, working in the Philadelphia region. My story isn't unique. In fact, it's been a story echoed by hundreds of thousands of healthcare workers since the announcement of the pandemic in the spring of 2020. What started out as an outbreak abroad quickly escalated to a global pandemic in September of 2020. There was over 1 million deaths reported. 6 months later, the number had doubled to 2 million. And by February of 2023, more than 7 million people had succumbed to the perils of COVID-19. It seems unfathomable that in the richest country in the world, that we account for more than 70% of the world's death toll from this preventable illness. Sadly, it seems the consensus is the answer lies with our blemished bureaucratic leadership. Instead of employing the scientific research to guide reasonable recommendations for others to follow, governmental agencies tasked with protecting public health and safety politicized the crisis and promoted vast mixed messages about viral transmission and the appropriate mitigation strategies, which created immeasurable chaos and mistrust. Essentially, by choosing not to take the precautionary measures to recognize COVID-19 as an aerosolizing transmittable disease until May of 2021, the CDC and like agencies recklessly facilitated the unnecessary infection and deaths of thousands of healthcare workers and patients throughout our nation. Those who had taken an oath to serve and protect our society abandoned us. As frontline healthcare workers, I speak for myself and my colleagues, we were unarmed warriors sent to fight a hopeless battle with no leadership. What we endured was isolation. No one came as we walked through the halls, masked day in and day out, paralyzed by our fears, but committed to our jobs and our patients. We battled with our leadership and begged our community through social networking for N95 masks, face shields from Amazon, trash bags doubling as isolation gowns, and clean gloves that weren't utilized previously. No one came to the bedside from our government officials as we tried to reassure families by the telephone about their loved one's arrival when they were not permitted to visit, and we knew they would never leave. When we FaceTime families to try to maintain some human connection, and again, when we attempted to resuscitate them after weeks of futile and torturous care. No one came when our patients realized they were dying and would never return to their beloved families. And the most we could do was offer the assurance we would stay, hold their hand, and make sure they did not die alone. For families, there was no closure, no goodbyes, no explanations to what happened. For nurses, we feared for our lives, but even more for our families, making the decisions to stay in different living areas or not seeing them at all, living in isolation with only our thoughts, recounting the deadly horrors we witnessed and would inevitably repeat in a few short hours. The emotional scars from our experiences cannot be erased. We cannot go back in time. We can only move forward, committed to making certain the tragedy of COVID is never repeated. As the advisory committee tasked with providing the isolation precaution guidelines, We want you to have the obligation to rectify the damage and mistrust you've created by being transparent and disclosing the science being considered to formulate your decisions, and be open to the outside contributions from panels such as this to guarantee your commitment to protecting our community's public health and safety for the future. Thank you.
Thank you, Kimberly. Thank you, everyone, for giving your very personal and moving statements. If you could please use the link in the chat to make your own recommendations for HICPAC and CDC. We will be trying to summarize all of these recommendations at the end of the workshop. Our next speaker is Dr. Raymond Tellier, who will be discussing aerosol transmissible diseases with a particular focus on influenza and COVID-19 as examples. Raymond, you can go ahead.
Yes, thank you very much. Let me just set up my slides. Yes, thank you very much. So I wanted to talk to you about aerosol transmission, taking the example of two very important pathogens. Dr. Milton has covered a lot of my first few slides, which is good. I'm be talking about respiratory viruses, which are thought to be transmissible by possibly three different pathways: contact, direct or indirect, large droplet, and aerosol size droplet, with the understanding that the relative contribution of each mode will vary depending on the virus you consider and or the settings. And I'm going to concentrate on aerosol transmission, which has long been deemed controversial in spite of the fact that there is a lot of scientific evidence for this, spanning several decades, in fact. And I will be concentrating on two important examples. The first one being the influenza A virus. The seasonal version is bad enough, but we also know that this is a virus that has a proven pandemic potential. If in the laboratory you make an aerosol suspension of influenza virus and from a cultured virus, and you studied over time all the infectivity decay, you will find that the virus remain infectious in aerosol form for a long time, for hours, provided that the humidity is low enough. At higher humidity, the decay will be faster. We have seen in Dr. Milton's studies and studies from other groups that you can recover exhale particle from subject infected with this virus. So, and you can separate them by size, and you can look in particular at the aerosol size fraction. And several groups, I'm not going to show them all, have demonstrated that if you recover the aerosol fraction exhaled by patient infected with influenza, you can detect influenza virus in these aerosol fraction by molecular methods. Now, many people will tell you, yes, but it's molecular methods, and you have not shown that this was infectious virus. And those of us who have actually done culture of virus in microbiology lab know that cultivating viruses is difficult. It is not as easy or as sensitive as cultivating bacteria. And what I'm trying to tell you here is that culturing, isolating influenza virus in cell culture is much less sensitive than detection by molecular methods. And this is compounded by the fact that aerosol collection method will often damage the virion, such that it will abrogate its infectivity, even though it's still detectable by molecular method. And so not detecting infectious virus by culture in the sample would not guarantee that there is no infectious virus. Conversely, if you detect infectious viruses, you can be sure that it's an underestimate. And there has been, in fact, studies that have shown that in the aerosol fraction of exhaled breath, not only can you detect influenza A by molecular method, but you can isolate the virus in cell culture in a fraction of case, which, as I've told you, is an underestimate. As you move further away from the patient, studies have been made by several different groups. And again, I'm not going to show them all, that if you collect aerosols from the air, from the air in healthcare centers, healthcare institution, you can demonstrate when you do that in season that you have in some aerosol fraction detectable influenza virus by molecular method. And I'm aware of at least one study in which they have also succeeded in cultivating and isolating in cell culture influenza A from aerosol sample collected from the room air in a healthcare setting. And again, this would be an underestimate. Okay, so influenza is present in aerosol-sized particle from infected patient. Do we know if these aerosolized influenza can in fact cause infection and disease? And the answer is yes. There's a very old study that was done in the 60s in which they experimentally infected human volunteers using an aerosol inoculum. And what you can show is that you can very effectively, very efficiently infect volunteer with influenza A virus administered as an aerosol inoculum. And then they could calculate the infectious dose. They could measure, in fact, the infectious dose, which is the amount of virus necessary to trigger an infection. Okay, and what they could show is that in experimental infection by aerosol, the dose was about 100 times smaller, roughly, than the dose that you need to experimentally infect subject by nasal instillation, which is to put influenza virus in liquid form directly on the nasal mucosa. So you need a lot less virus by aerosol. Not only that, but if you look at the disease that these infected subjects develop, what you found is that by the aerosol route, they will replicate the whole spectrum of disease from asymptomatic to upper respiratory tract infection to some of them having viral pneumonitis, whereas experimental infection by nasal instillation produce an attenuated disease. And incidentally, subsequent to these findings, it is no longer permitted for biosafety reasons to do experimental infection of influenza by aerosol on human subjects. So these two aspects of aerosol infection, a lower dose and an association with severe disease, is very typical, is a good example of a concept that was introduced in infectious disease by Dr. Donald Milton, which is anisotropic infection. For those infections that can be transmitted by several modes, what is proposed is that different modes are associated with different minimal infectious dose and different severity of disease. And the example that Dr. Milton proposed in his groundbreaking article was that of smallpox, which caused a much more severe disease by aerosol than by cutaneous inoculation. And I put it to you, influenza A is another example of an anisotropic infection. And that's another reason why we should be concerned with aerosols, because they very likely are associated, infection by aerosol is associated with more severe disease. There has been outbreaks of influenza where aerosols seem to be the culprit. This is a famous incident having occurred in a plane immobilized on the tarmac with the ventilation shut down, which would be expected to increase transmission by aerosol, but would not affect large droplet or contact. And what was seen is a very high attack rate. There has been another interesting outbreak in a hospital in Hong Kong where the source patient was here in a ward that had 3 bays, and there were secondary cases in only 2 of the 3 bays, even though they were attended to by the same nursing and medical staff. And these patients were all too sick to get out of bed. So the distance between the source and the other patient is too big to be explained by large droplet. And we know that in contrast to large droplet, which can infect only at close range, aerosol have a potential to transmit at long range, as well as being present, of course, in higher concentration at close range. And it does. The other thing that is remarkable in that outbreak is that you will note that the secondary cases are scattered. And this is actually a feature of aerosols. Aerosols with infectious agent in them will spread in a room in a random manner, and a random distribution is not the same thing as a uniform distribution. And in this particular case, what was found is that there was a ventilation fan on that wall here near the source, the index case, that was mounted backward and was blowing air in the room instead of out of the room. And they put a smoke tracer to see where the smoke, which is a marker for aerosol, would go. And then you can see that the distribution of the tracer overlap perfectly well the distribution of secondary cases. And so it supports aerosol transmission. This is a very old experiment that was done at the onset of the pandemic of 1957 of influenza A in a VA hospital, where they had one wing of the hospital dedicated to tuberculosis, where there was UV irradiation of the ceiling as protection for aerosol, and they took control patient in another wing. Now, the way that this works is that you have UV lamps that are hanging from the ceiling, irradiating upward. And so you have a killing zone in the upper air of the room, and only small aerosol that can be carried by hot air columns can rise to enter the killing zone. And when they will shower again in the room, the infectious agent would have been inactivated by UV. And what was seen is that even though in these two wings, they both were receiving visitors and were attended by the same staff, the virus got introduced in both wings, but in the irradiated wings, it did not propagate, whereas in the other wings, it did trigger an outbreak, and this support against aerosol transmission role for influenza. This I will skip. Lastly, I will point out that there are several different animal models for influenza in which aerosol transmission has been demonstrated, including ferret, horses, quail, swines, and guinea pigs. And this is just a schematic of one of these aerosol transmission experiment between ferrets, which also this particular one I like because it shows that not all strains of influenza A are equally good at aerosol transmission. And in this case, it was shown that the H1N1 pandemic strain in 2009 was much better at it than the previous H1N1 that has been circulating for years as seasonal virus and that presumably had become a little bit attenuated. And what is suggested here is that the capacity of a virus to cause pandemic depends on a great deal in its capacity to spread by aerosol. The other example I wanted to submit to you is that of COVID-19, and the demonstration followed pretty much the same pathways. Aerosol produced in the laboratory showed that the infectivity decays only slowly, so that you have infectious virus remaining for hours. If you look at aerosol sample collected from the exhaled breath of infected subject, you will detect the COVID virus by molecular method, and in a fraction of cases also by culture, again, likely underestimate of the infectious dose. There's been several studies, and I'm not showing them all, of detection of the COVID virus in aerosol sample collected from the air of rooms in healthcare setting. And in some cases, we're able to demonstrate that the virus was infectious by isolation in cell culture. There's been outbreaks that are unexplainable other than by the aerosol route, including these famous cases of an outbreak early in the pandemic in a choir rehearsal group that has been analyzed in great depth. This was an outbreak early in China occurring in a tourist bus, and you can see that the index case was here, and several of the secondary cases were way too far to be accounted for by direct contact. And again, you will note the scattered location of the different cases, which, as we know, is to be expected by aerosol transmission. This is another outbreak that occurred very early in China in a restaurant in Guangdong province, and the index case in this restaurant transmitted the virus to other patients that it was found out were in a zone that was an envelope of air being recirculated by the air conditioning unit here. And there was no case outside of that zone of recirculation, and careful analysis of security camera ruled out direct contact as an explanation for this outbreak. This is another one that is very suggestive. So this is an outbreak that occurred in a church where the source cases was the singer and piano player who was on an elevated podium and having his back turned to the audience. And so if you want to explain that by large droplet, the large droplet moving forward would have had to rebound on the piano and travel several meters, which a large droplet cannot do. And so the only explanation really for this transmission event would be by aerosol transmission. The other thing also is that you have, I'm almost finished, Lisa, you have animal model experiment. This is transmission in the Syrian hamster model in which they could transmit the disease by either direct contact or intranasal inoculation of aerosol. But this is further suggestive to me is that there was a suggestion that by aerosol transmission, they were getting sicker. This is another example of aerosol transmission involving ferrets. So you had the donor ferret that was in the lower cage, and you can see that through this apparatus in which only aerosol could travel, the recipient could successfully be infected in experiment involving influenza A or the SARS-CoV-1 or the SARS-CoV-2, which is the agent of COVID. I will also point, and this is my last slide, Lisa, that there's also a lot of data on other viruses. This is very old data that we've known for decades, showing that adenovirus can also be transmitted by aerosol, and that it too is anisotropic, and that the dose by aerosol is lower than by intranasal inoculation and is associated with a more severe disease. Thank you very much.
Oh, Raymond, I am really impressed. Thank you very much. That was the fastest overview of two very complicated organisms.
Wait, Lisa was expressing, and very appropriately, I might add, skepticism that perhaps I was trying to present too many slides, but you've been a great audience. Thank you.
Thank you. Our next speaker is Dr. Bill Bonfleth, who will discuss ventilation control for aerosol transmissible pathogens in healthcare settings. Go ahead, Bill.
All right, thank you, Lisa. Let me get my slides up here. I was prepared to do this in 10 minutes, and they've given me a little bit more, so I will be expansive, but hopefully not too expansive. So this follows up on very well on some things that Ramon just said about some of these outbreaks, which you may have noticed occurred in indoor environments of one kind or another, whether they're stationary or mobile. So it's appropriate to talk about ventilation controls or engineering controls, and that's my brief here. I did want to start with one note about how the building science community reacted to the pandemic. This is a statement that was put out by the ASHRAE Epidemic Task Force, which I chaired. It started operation in March of 2020. And the first thing that we put in writing was that we think there's enough reason to believe that there's airborne transmission of SARS-CoV-2 that we ought to do something about it. And of course, then we spent over a year arguing with public health authorities about whether that was true or not. So that's been my experience, and hopefully we can move forward more productively now. So let's place engineering controls, ventilation in context. Risk mitigation, we've come to understand in the last few years, involves pyramids and Swiss cheese. We have the famous NIOSH hierarchy of controls that tries to clarify the order in which controls should be applied for maximum effectiveness. And we see that engineering controls are somewhere in the middle of this this hierarchy, in between getting rid of the source, which is impossible for something like a respiratory infection that's being transmitted, and PPE, which wind up at the bottom because of the way people comply with them, wearing their surgical masks under their nose, for example. The Swiss cheese model, which didn't come from infection risk assessment, it's a widely used analogy, just tells us that the having multiple controls that are fairly effective is better than having one that's really effective but may have a weak link in it somewhere. So we want to not leave engineering controls out of the picture when we consider how to reduce the risk of contracting an airborne infection. And as Raymond already indicated, there's a lot of evidence that there's airborne transmission, and there's also a lot of evidence that environmental controls have a role in how it's transmitted. You saw in the Guangzhou restaurant case how the circulation pattern set up by the HVAC determined who got exposed. A case that I find really compelling is a nursing home incident in the Netherlands that was briefly reported on way back in 2021. So this was a nursing home with 7 wards, and in 6 of the 7, there were at one point in time 0 COVID infections, no residents, no staff. In the 7th, in the same time period, they had 81% resident infections and 50% healthcare worker infections. And the healthcare workers did not move between wards. So this was all within this one ward. The interesting thing from the point of view of my topic is the HVAC systems. So 6 of the wards had 100% outside air systems, once through outdoor air, and it was not modulated to save energy. It was always at the intended maximum value. The 7th ward had been retrofitted for energy efficiency, and they put in a carbon dioxide-based demand control ventilation system that would actually shut off the outdoor air if the concentration indoors was below 1,000 parts per million. So air was being circulated throughout the ward by this system with very poor efficiency filters. It seems to be fairly strong evidence that if we don't take reasonable care in how we design our HVAC systems, then we can expect these sorts of things to happen. And there are many other case studies that show transmission through plumbing and others that we don't have time to go through today. Now, I want to point out here that ventilation means more than just outdoor air, although some are confused by that at times. If we look at the American Society of Heating, Refrigerating, and Air Conditioning Engineers standard for ventilation in non-residential, non-healthcare buildings, it defines ventilation as the process of supplying air to or removing it from a space to control air contaminants, humidity, temperature within the space. And it also defines something called ventilation air and says that it's outdoor air plus recirculated air that's been treated to maintain acceptable IAQ. And so the importance of this is that we can control our indoor exposures by means other than bringing in more outdoor air. And we've already heard people talk about using filters here, and that's what we're talking about. So airborne transmission is a dose response phenomenon. The higher the dose we inhale and it deposits in our respiratory system, the more likely we are to be infected. So if we can reduce the exposure, then we are likely reducing the risk. And we can see in the Wells-Riley model of infection, it's a model that's widely criticized, but as Bach said, all models are wrong, some models are useful. It's a useful model. We can see that the risk of infection, P, new infection, is decreased in proportion to the clean airflow that we provide. So this supports the idea that I'm talking about here. And another thing that we see from looking at the Wells-Riley model is that no ventilation, no clean air delivery is bad. Some really improves our risk a lot, but at some point we get really diminishing returns. And you can see that from the shape of these probability versus ventilation rate curves from a report that was done by Brett Stevens a few years ago. So this is what we're trying to do, reduce the concentration in the air that we're breathing. So this equivalent clean airflow metric is really a great unifying concept for designing control strategies. The definition you see here comes from a new standard, ASHRAE Standard 241, control of infectious aerosols that I chaired. And I think it's a simple enough definition that it says that it's the amount of pathogen-free air that if we could distribute it into the breathing zone of people would have the same effect as other controls, filtered air inactivated by UV. And so we can assign an equivalent clean airflow to every control that we're using, and we can add them together, and we can do risk assessment based on the probability of infection as a function of the equivalent clean airflow. That's what we've done in the standard. So how can we treat air in a space to reduce the exposure? And we've talked about a lot of those things in various parts of this discussion already. Dilution with clean or cleaned air is one way. So outdoor air is just one source of that. Filtered air that we introduce as part of the ventilation supply is another. That can be done centrally, or it can be done with in-room devices. And then disinfected air, either centrally disinfected or in room. What you see in the upper photo here is a large space that's got an upper room ultraviolet system in it, and you can see the fixtures on the wall. Local exhaust is a great way to reduce exposure. If you're going to use local exhaust, that means you know where the source is. So this is something that can be applied, for example, in a patient room where you have an infected person in a bed. Not so good if we're trying to make a cafeteria or a break room safer. Pressurization is another way to reduce exposure. I think of pressurization really as being a kind of airflow control. If we have higher pressure in a space, then it's going to tend to leak outward and be protective. If we have negative pressure between spaces, then air will tend to leak in, and that's used to isolate, a very important and common strategy in healthcare facilities. And then we have all of the different air cleaning and treatment technologies that are available, from those that have been around for a century and have a huge literature documenting their effectiveness, to others that are still at best emerging technologies. So germicidal UV is one that's been in use for a long time. It was used in tests on measles risk mitigation in schools in the 1930s. So we have evidence going back that far. And then there are a lot of reactive species air cleaners that produce ions or various kinds of radicals, hydrogen peroxide, etc. All of these are at least potentially technologies that we can use. So we've looked so far just at how much air do we introduce into a space. And it's important to understand that it's not just the gross amount of dilution that we provide, but whether we get that cleaned air to where it needs to be. And we can, I think, conclude that air distribution is of equal importance or comparable importance to the amount of ventilation itself. So air currents can reduce risk or they can elevate it. In a healthcare environment, clean to less clean is generally the guideline that's used. So we set up pressurization controls to make that happen. The photo here on the right comes from a study that was done by Hugo Lee from Hong Kong and Peter Nielsen from Denmark and Matt Sandberg from Sweden. And what this is showing is someone exhaling particles that can be visualized in a test chamber, and this happens to be a stratified chamber. So we're pushing air in from the bottom up to the top, supposed to be good for indoor air quality. But what we've learned is that for infectious aerosols that are exhaled, they get outside the human thermal plume and they can stratify in the breathing zone. So these things are very important, and we actually still have quite a bit to learn about them from the point of view of developing standards and guidelines. What standards do we have? ASHRAE has its standard co-developed with ASHE, the American Society of Healthcare Engineers, for healthcare facility ventilation, and then standard 62.1 for non-residential buildings, and the new standard 241, which is not a general air quality standard, but only an infection control standard. And I also took a look in preparing for this, the CDC guidelines for environmental infection controls in healthcare. Those are 2003 updated in 29. I won't say much about them here. I want to say a few words about these other standards. So ASHRAE 100 has a high level of protection in some spaces. It's easy to see that from looking at it, but it's similar or even worse than ASHRAE standard 62 for a lot of other spaces. It's a unique standard in that it specifies ventilation and air changes per hour rather than in actual absolute flow units. And the approach is generally to have moderate to high outdoor air provided, but then a lot of recirculation through efficient filters. So this idea of equivalent clean air is really implicit in the way these standards are designed. It goes all the way up to HEPA filtration. 62.1 is an acceptable minimum indoor air quality standard. It doesn't deal with infection risk, and it specifies ventilation per person and per unit of floor area. The brand new ASHRAE standard 241 that was published in July only addresses infection control. And so it refers to what we've called infection risk management mode. Someone has to decide when there's enough risk to invoke it. The baseline for it is standards like 62.1 and 170. And the requirements in it are given in terms of equivalent clean airflow per person, not outdoor air, but equivalent clean airflow. So you can decide which controls to use as long as you have the minimum outdoor air that's provided or required by the baseline prerequisite standard. And we have about 25 space types that are included in it now. That'll be expanded. Several of them are healthcare spaces, and the rates recommended for those go from 40 to 90 CFM per person. And if you're familiar with ventilation rates, those are actually pretty high. So this is an aggressive standard in terms of what it's proposing. A little bit of information here on what's in 170, just to show how widely things vary in that standard. So on the left, we have some non-critical spaces as they might be defined: a patient bedroom in a behavioral mental health facility, 2 air changes per hour of outdoor air, 2 of supply air, and a MERV 8 filter. Outpatient examination room, 2 air changes of outdoor, 4 of supply air, MERV 8 filter. The MERV 8 filter is actually lower than the minimum filter efficiency that you have to put into your home in California, and it's much lower than the MERV 13 that the updated CDC COVID guidelines are recommending. When you get to a patient room, we now have a good filter, a MERV 14 filter, but still only 4 supply air changes. If we look at the high value spaces, an airborne infection isolation room, negative pressurization and 2 air changes of outdoor, 12 of supply, MERV 14 filter, protective environments similar, but positive pressurization and a HEPA filter, and an operating room, 20 air changes of supply with a MERV 16 filter and 4 air changes of outdoors. So there's a big range there. And one of the things that we learned during the pandemic was that people can be infecting others anywhere in a healthcare facility. So we can't just focus on these special environments. I think, yeah, sorry, a couple of slides here. Areas of concern that we have that warrant improvement to standards. We saw there was a problem with surge capacity at the beginning of the COVID pandemic. You can see that the level of protection in non-critical spaces, so-called, is low in some cases. We need to do better there. Outpatient facilities are really sketchy, and so are residential care facilities where some of the worst outbreaks took place. So there's a lot of reason to do that. And here are my conclusions. Controls are important. We can't neglect them, but they're only one part, so we can't expect them to do everything. Removal and dilution combined with airflow control, very simple principles, but sometimes hard to implement. I think risk assessment needs to be done to justify them. We've been using for a long time pretty much empirical ventilation rates that we know work, but we don't know if they're sufficient or absolutely necessary. Equivalent clean air is the way to go because that will allow us to have sustainable facilities that are also safer. And there are a lot of reasons to do better. So I've gone over a couple of minutes here, but I hope that's not too much of a problem. And thank you. I look forward to the discussion.
Thank you very much, Bill. We appreciate your presentation. Our next presenter is Dr. Lisa Brosseau, presenting on personal protective equipment for aerosol transmissible diseases in healthcare. Lisa?
Sorry, finding my presentation. Got it. Okay. So I'm going to talk mostly about respirators, although this is called equipment for aerosol transmissible diseases in healthcare. I'm an industrial hygienist with expertise in respiratory protection and exposure to hazardous aerosols, including infectious aerosols. So Bill talked about the hierarchy of controls, and it is a core principle for both patient and worker safety. I found that during the pandemic, using a source pathway receptor approach to discussing the hierarchy of controls is a good way to illustrate the different levels of controls and types. The priority has to be on minimizing aerosols at the source, and that means in minimizing the number of people in a shared space, using source controls like respirators, or eliminating sources by screening or testing. But if these are not effective at limiting the emission of hazardous aerosols, then controls that interrupt the pathway from source to receptor are the next option. And those are the ones that include ventilation, such as Dr. Bonflet just discussed. The lowest priority are those that limit exposure at the receptor, and that is mostly personal protective equipment. And you need to do the first two first before you utilize respiratory protection. As was mentioned by other speakers, respirators work. The HICPAC work group suggests that surgical masks are equally capable at protecting people from infectious aerosols, but this is not true. You've seen plenty of data already to demonstrate this. There are numerous studies, many of which OSHA relied on when updating its respiratory protection standard, that demonstrate the efficacy of respirators in workplace settings, using workplace protection factor studies, for example. OSHA found that a negative pressure half face piece respirator, like an N95 filtering face piece respirator, is capable of reducing the external aerosol concentration by 10 times. So that's an assigned protection factor of 10. This is only if the respirator has been fit tested, however. There's no need for clinical studies of respirators in healthcare. I should note that the 95 refers only to the filter efficiency and not the overall protection of the respirator. And 95 refers to the efficiency when the filter is tested at the worst case conditions, which means that the filter will collect workplace aerosols with much higher efficiency than 95%. Surgical masks were originally worn to prevent emission of bacterial aerosols from the wearer, although randomized controlled trials have shown that they are not effective for this original purpose of preventing surgical wound infections. Today, they are also worn to prevent exposure to splashes, sprays, and droplets, although a face shield would be a much better choice for such exposures. Surgical masks do not prevent the emission or an inhalation of the small infectious aerosols that Drs. Milton and Tellier described. This table illustrates the difference between cloth and surgical masks and respirators. The left two columns show the degree of outward and inward leakage, where the lower the number, the better. The third column shows the filter efficiency, where the higher the number, the better. And the fourth column shows the breathing resistance, and the lower number means it's easier to breathe through. This table illustrates that N95 filtering face piece respirators have very efficient filters, and because they're designed to fit well in the face, very low inward and outward leakage. Surgical masks are highly variable. Some, like the 3M 1818, have good filter efficiency, and can be fitted fairly well to limit inward and outward particle movement. But a procedure mask, on the other hand, has a less efficient filter and lots of inward and outward particle leakage. Cloth masks generally have very inefficient filters and have a lot of inward and outward leakage. So as demonstrated in the last slide, fit is important for limiting inward and outward leakage of particles, although good filter efficiency is also important. Numerous studies have demonstrated that it is impossible for people to determine whether they have a good fit without some form of testing. We are simply not very good at determining if a face piece is leaking on our face. That's why OSHA requires that workers are fit tested when they're required to wear a respirator. And fit testing is specific to the respirator manufacturer and model and size. While most healthcare organizations use qualitative fit testing, which depends on taste or smell to detect leaks, quantitative methods are better and are considered the gold standard. If each healthcare worker had been given an elastomeric respirator at the start of the pandemic, there would have been no supply issues and more respirators would have been available for other essential workers. This type of respirator has a lot of advantages. It's reusable, it's cleanable, it's easy to maintain. Every person can have their own. They are easy to fit test and check for that they actually fit when you put them on. They fit consistently over time, and while initially they're more expensive, they can result in considerable savings in a relatively short period of time. There are models without exhalation valves now and with speaking diaphragms that allow for better communication. NIOSH has been doing a lot of research on the use of elastomeric respirators in healthcare over the last 10 to 15 years, which CDC and HCPAC should encompass in the updated isolation precaution guidelines. Tight-fitting respirators can be uncomfortable over time, especially if they're worn for many hours. Moisture, pressure, sweat, and friction can contribute to skin irritation and damage and dermatitis. Some of these issues can be alleviated by receiving a well-fitting respirator and wearing the respirator correctly. In other words, it does not need to be tightened too small or tightened too closely to the face. As well, some respirator manufacturers have recommended skin protectants and barriers. Limiting the amount of time a respirator is worn and allowing for breaks can also minimize discomfort and skin problems. And there are other types of respirators, such as powered air purifying respirators, that are more comfortable and appropriate for long wear times, especially when other PPE adds to the overall burden. There have been a few studies suggesting that universal masking was effective at limiting healthcare-acquired infectious respiratory diseases, including but not limited to COVID-19. I've listed just a few of these here. It would be very appropriate for HCPAC to review the published studies, all of them, of universal masking and universal respirator use when updating the isolation precaution guidelines. Just as the use of gloves have become a core practice, the wearing of masks or respirators by all healthcare workers would be an appropriate core practice, particularly when there is increased incidence of infectious respiratory diseases. Instead of focusing on the minimal protections, HCPAC and CDC need to consider the science that supports the best and most feasible protections for healthcare workers and patients. And by best, I mean protective. So they need to consider protection and feasibility together. They need to include all stakeholders, including patients and healthcare workers, in their decisions. And they need to encourage the inclusion of workers and patients in policy making and implementation in each healthcare setting. And CDC needs to work hand in hand with OSHA in the development of guidelines that recognize and protect everyone from aerosol transmissible disease. In a very limited literature search I did in the last few days, I found numerous articles reviewing and discussing infection control guidelines and practices for the future. Rather than wasting time with flawed evidence reviews comparing respirators and surgical masks, I strongly urge CDC and HCPAC to seek input from scientists and infection prevention professionals across the world on lessons learned before and during the pandemic. Thank you.
Thank you, Lisa. We now have about 15 minutes question and answer with the previous speakers, moderated by Dr. David Michaels. Also joining us is Dr. Barbara Materna. So please put your questions for the panel in your question and answer box. Thank you.
Great. Thank you, Mitch. We've heard some excellent and very important presentations, and I also see there are already a ton of really great questions. We're going to try to get to as many as we can here. We heard from Dr. Tellier about the centrality and mechanisms of airborne exposure, and from Dr. Bonfeth about the environmental engineering controls, including ventilation and filtration, and other means to treat air that prevent exposure, and the failure to implement these controls leads to exposure and illness. And then we just heard from Dr. Brousseau about the importance of the hierarchy of controls, keeping infectious people out of the workplace, which is difficult in healthcare facilities, and then of course engineering controls, but beyond that, PPE is so often needed, and then we need respirators. The literature is clear, N95s and elastomeric respirators work, but surgical masks and cloth masks are not respirators and they're not protective. So let's take off from there. Maybe begin with a question for Lisa. Why isn't the CDC recommending actual respirators, but only surgical masks for seasonal pathogens? Is there an N95 shortage? Shouldn't the new CDC guidelines recommend respirators for these aerosol transmissible pathogens?
Yes, I think they should, but first we need to get them to recognize that those are aerosol transmissible pathogens. So that's the key, is to ensure they understand the science and that they encompass a much wider range of organisms and pathogens in their discussion of aerosol transmission, which of course then will lead to the requirement for respirators and not surgical masks in healthcare settings.
That's right. Well, let's take off from that. So, Raymond, you talked about influenza and COVID-19 as aerosol transmissible diseases. So are there other diseases, other infections you'd put in this category? And
to be sure,
need for them and for COVID-19 still?
To be sure, there are others. I've given you the example of adenovirus, for which there's a fair amount of data. Some viruses have not been well investigated for that, such as RSV. In fairness, there may be some virus for which aerosol transmission is not very important, for example, rhinoviruses, at least some strain. But some diseases that are classically transmitted by aerosol include measles, include chickenpox, which is quite common. Tuberculosis is the example by excellence of a classic aerosol transmitted disease. There are also some other diseases that are very peculiar in that they are acquired by exposure to an infectious aerosol, but then the infected patient himself does not become contagious. And so example of that would be Legionnaire's disease, the systemic mycosis, histoplasmosis, and blastomycosis and coccidiomycosis. You would have Q fever, that would be another example of that. So these are diseases which are and currently avian influenza H5N1, which has to be acquired by exposure to an aerosol, because the virus can only replicate in the lower respiratory tract in its current form. And there has not been to date in its current form transmission between patients, but we know that the avian H5N1 could mutate to become transmissible from human to human. And one of the reasons why I'm so eager to push for aerosol protection is not only for the agents that we do know, but for new emerging pathogens that are going to come our way. And it's not bad science fiction. We've seen it often enough now. We're still living with COVID, and there are more dangerous viruses that are lurking in the threshold.
Great. I'm glad you brought that up. Thank you. Well, let's bring Barbara into this. Barbara, it's great to see you again. So healthcare organizations say that respirators are too difficult to implement. So how should the CDC guidelines address this, do you think?
Well, at first I would point out, oops, I seems like my video is freezing. Can you hear me okay?
Yes.
Yes.
Okay, so first I would point out that respirators are used successfully by many different kinds of workers in a wide range of industries and have been for years. I think healthcare is slow to acquire the skills necessary and the recognition of where they're needed, as Lisa mentioned. So the updated CDC guidelines must make it clear that where infectious aerosols pose an inhalation hazard to healthcare workers, these are one of the necessary control measures. And they also need to make it abundantly clear that they must be used within the context of a full OSHA compliant respiratory protection program that includes all of the elements from carefully done fit testing to thorough training. There are many resources available to help employers understand how to implement respirator programs, but workers using respirators won't be effectively protected if enough effort, and that includes staffing and resources, is put into implementation of a full program.
Let me stay with you for a minute, because doesn't the California ATD standard require respirators for certain designated pathogens?
Yes, currently the standard is based on the 2007 guidelines. So for all of the designated as airborne diseases, yes, respirators are required during COVID. In addition, the standard requires respirators for pandemic, new pathogens, novel pathogens. And so COVID was brought in under that. And so there was a clear requirement for respirators. So the updated CDC guidelines should adopt that same sort of requirement for novel pathogens while we're trying to figure out the extent of aerosol transmission. We should just presume that they're transmitted through the air.
Great, well, thank you. So let's now move back up the line to engineering controls. And Bill, it's not easy for some healthcare settings like long-term care facilities to install negative pressure rooms. So what would you recommend instead in those sort of facilities that would limit the movement of infectious particles from one room to another?
Yeah, I think that's a tough question, because the HVAC systems in those sorts of facilities may not be much different than any other commercial building. One thing you can do if you don't have pressurization is at least make sure that that you have good seals on doors. So if you can contain the air within the space, that's a good start, and then you can put air cleaning in it. There's been at least one study I've seen of a long-term care facility where they really couldn't stop the spread of infectious aerosol from one space to another, but with high levels of air cleaning in the spaces, they lowered the levels so much that it had a beneficial effect. So you can do that, and you can try to control the airflow in the rooms too. If you've got a system that recirculates like the one I mentioned, finding somewhere else to send the return air, and so that it doesn't mix with air from other spaces is one possibility.
Well, let me follow up on that, because there's a lot of discussion in healthcare facilities around operating rooms and ERs and patient rooms, but aren't we talking about exposures to both healthcare workers and patients in corridors, in nursing stations, in waiting rooms, in break rooms? Shouldn't the CDC guidelines address these risks?
Yeah, they should, and actually I would say ASHRAE standard 170, which is the basis for a lot of design, should address it. I was just appalled the first time I opened it to see that there were all of these space types in healthcare facilities that were not as well treated as an office building would. So you have low filtration amounts, you have only moderate outdoor air amounts. I think we have to recognize that we don't necessarily know where the infected people are in a healthcare facility. I think that's kind of implicit. Oh, there's an infected person, we put them in an airborne infection isolation room, but that COVID proved that that wasn't the case. So we need to raise the bar for all of these other ancillary spaces, whether they're care spaces or not.
Wow, thank you. Lisa or maybe Barbara as well. Our hospital system has difficulty, with defining AGPs requiring N95 respirators for providers or other healthcare staff. Are there any comprehensive specific lists that indicate the required use of N95 respirators or other respirators for staff performing these procedures?
That's a really good question. I don't know of a comprehensive list, but I will tell you that during the pandemic, there's been lots of research, published research on what is an AGP and how much aerosol is, created by different medical procedures. I think that CDC and HCPAC would be, it would be a good thing for them to do a thorough review of the literature to determine what should fall in this category. There have been several publications over the pandemic, which I think is sort of interesting, that suggest that people are better aerosol generators than most medical procedures. I don't think we should discount aerosol generating procedures. However, some of them, maybe not all, can generate really high concentrations in very short periods of time. That's a very risky situation, since exposure is a function of both concentration and time. So a high concentration for a short time can be equally as risky as a low concentration over a longer period of time. So I do think there's better science. I think there's been some research, and I think there could be more research in this area. But I don't think we should completely neglect aerosol generating procedures altogether, simply because some on the list right now don't fall into aren't equivalent or don't generate as many particles as people do. I'm not sure that's the category. I'm not sure that's the comparison that I would necessarily make.
I agree. And, we really do have to look at the evidence. That actually relates to a question I've gotten here, which is, are federal or state occupational safety and health regulations require evidence-based practices or the use of, evidence-based hierarchy of controls to measure, identify, characterize, and manage workplace risks? And relate to that, does the CDC guidance, which isn't evidence-based, as we've all discussed today, outrank federal or state occupational safety and health legislation? And this is a big problem. If OSHA issues a standard, and OSHA started working on a airborne infectious disease standard when I was running OSHA in 2010, after the H1N1 epidemic, we started reviewing all the literature and said, okay, we're going to have a standard based on the evidence, and it applies the hierarchy of controls. It's very straightforward. CDC has not done that. It's very unfortunate. They've looked at a little piece of the evidence. They've looked at what we call sort of pragmatic randomized trials, which are trials that are not really set up well to answer questions, but also you don't need randomized trials to understand the effectiveness of respirators, and certainly to compare respirators to surgical and cloth masks. And we saw that from Lisa's presentation. But CDC isn't doing that, but because of this sort of dynamic within the government, OSHA defers to the CDC, which I think is a terrible mistake, because the CDC's process is not an open one. It doesn't require a true evidentiary review. And as a result, both workers and patients are at far greater risk. It's really unfortunate. I don't know how much time we have left for.
I think we have about a minute.
Yeah, we have about 1 minute, David.
We'll do one last question. We'll big Barbara in here. That, as you know, during the COVID pandemic, a lot of facilities were not prepared. There were immediate and severe respirator shortages. Other PPE was missing. Should the CDC guidelines require healthcare facilities to stockpile respirators and other PPE so there are sufficient supplies during surges of infections and outbreaks?
I think that's a really good point. We should have known from the H1N1 pandemic and, just the normal expectation that there needs to be thought ahead of time. Overall, the federal government and state governments let their stockpiles didn't replenish them when needed. So the overall idea of preparedness, including having enough healthcare workers trained and ready, respirator ready, even if on a daily basis they're not in high risk situations, it's really important. I believe there's been California legislation requiring stockpiling, and CalOSHA has been involved in, assisting that determination on how much stockpiling would be needed. But it's definitely a consideration that should be addressed so we're not in that situation again.
Great, thank you so much. I'll turn this back over to Mitch.
Thank you very much. Thank you, David, Ramon, Bill, Lisa, and Barbara for this great discussion. The next part of our program, we've invited 4 additional stakeholders, frontline healthcare workers, a family member advocate, to talk about their personal experiences with infection prevention and control in healthcare settings. Our first speaker is MJ Burke from the VA Council. MJ?
Hey, thanks for having me. So let's talk about what problems we encountered. I work at the VA, and we are the largest healthcare system in America. Traditionally, we really had a safety program that was robust, but being the largest healthcare system, we even faced a lot of challenges during COVID. So I'm going to go through like 3 problems, and they were all covered. I seem like a genius, when we have all these PhDs talking about this stuff. But I think from a frontline perspective, when things don't seem right, you heard like Kim about it, who is the ICU nurse. It gives me reassurance that we have like these scientists behind us that are echoing things that I know even like by infection control doesn't make sense to me. So problem 1, and this is really, I wrote this before all these, I heard all these. I have not seen CDC studies for COVID that replicate real life occupational task demands. And what I mean by that, even my coworkers, as a physical therapist, if you're dealing with infectious disease, especially respiratory, I want to kind of talk you through. You have to go down like someone's supine, you grab their inferior angle of their shoulder. So you're like this close to their face with a surgical mask, and you're hoisting them up, and then you're just holding them because they're so weak. So 2 things, the vicinity is a lot closer than people would think. And then 2, you're moving those secretions up, and you know what's going to happen. And I have a surgical mask on, especially early in the pandemic. And the conversations we had with nurses, especially about activities that were not respirator worthy, things that kind of don't make sense to me, like, you find 50% RNA COVID positivity and diarrhea. We use these air mobility mattresses, and yet that activity wasn't respirator worthy. Just like dementia patients at CLC units, you're having to help them do exhale, through that. And a lot of those at the time weren't respirator worthy. So when there was a question about lists, the things that were airborne was like they said aerosol procedures, which are typically EGDs, nasal swabs, respirator nebulizing treatment, and that was it. I mean, we could not get a respirator if it wasn't kind of on that list. And so I think before you rule out stuff for aerosolization, I think you have to have those studies. Otherwise, you should plus up the isolation procedure. 2, you heard people talk about reuse and contingency options during the pandemic. I called it the brown paper bag syndrome, where they were being asked to reuse respirators. And I didn't even know what an elastomeric, I had seen elastomerics before, but I didn't know they were readily available until like way after. And when I found out, like small facilities in Texas for TB had always used elastomerics, the fact that we were doing brown paper bags should have never, ever been on the CDC website. And that really kind of angers me. And when a facility is not required to give public notice when they go into contingency operations, whether that's for staff and they don't have enough staff to cover isolations, or they have to double cohort rooms for isolation, or they don't have respirators, it makes like the CDC guidance kind of a mockery when it's like kind of optional if available kind of thing, because at the very least you should be having to give public notice if you're going below some of these things that are really more evidence-based. And number three, this wasn't talked about, but I think it should be talked about a little bit more, is training and CDC communications regarding isolation transmission recommendations. I mean, some of the things is like the posting of Contact Plus, Droplet Plus, and even, Airborne Plus. All these signs look different. I don't think there's a requirement necessarily to put like what that graphic image of what it should look like when you go in the room. They all are different. Every facility is kind of looks different. And so as a consequence, you get like variation of like, well, what is this? And a lot of training is done on a computer rather than in reality. And so the recommendation there is like, I think we should be doffing, especially PPE on a quarterly basis, making sure that we're doing the right procedure. There could be a lot of cross-contamination there. To give reference, like we do CPR on a quarterly basis, and we're doing like the most deadly thing, and it's kind of like, do a computer-based model. So I think there are some very helpful, very practical things that we can do to make things better. And actually mine were the same for Lisa. Recommendations, elastomeric for a big system like that should be in your emergency response caches. Notice to public workers when you're not in conventional status, whether that's room, respirator availability, or shared room cohorts due to staffing, and coworkers looking at you, doffing especially PPE in the full garb, done on a quarterly basis, because we will always have some sort of novel respiratory, and that's it.
Thank you very much, MJ. And we appreciate your comments very much. As a reminder, please put your recommendations for the CDC in the link that we've provided. And Jane just put it back in the chat box. Next, we have Rita Lewis, who's a nurse with experience in correctional facilities. Rita?
Hi, and thanks so much for having me. Okay, I'm a retired registered nurse, and I worked for 15 years with California Correctional Healthcare Services at San Quentin State Prison. So I'm speaking for the incarcerated population and those of us who serve them. The point I would really like to make is that it can never be assumed that the Department of Corrections will practice common sense or prioritize the safety of inmates, employees, or the community. They have books of considered policies and procedures, but just like in the movies, prisons are their own bizarre, dysfunctional fiefdoms under the control of wardens and department managers' whims. Cal Human Resources issued a really detailed memo about COVID and risks and recommendations. And then the governor issued his executive stay-at-home order in March of 2020. Many state offices packed up their desks and became teleworkers. Essential departments were the exception. And for corrections, this provided justification for maintaining the status quo. In April of 2020, in my role as a union steward, I reached out to the leadership. I was perplexed by the fact that while the world was on lockdown, there were really no efforts to curtail staff or inmate movements at San Quentin. That they did grant some inmates early release, but with staff, it was business as usual. I couldn't understand why the movement of staff, vectors, in and out of the prison, a contained environment, wasn't being curtailed. Of note, when it's foggy, they institute fog line and minimize movement for safety reasons, but nothing was really happening. There were no modified schedules. They didn't put us on weekend holiday schedules or like a graveyard shift type schedule that minimizes employees, or alternative schedules, 12-hour shifts to reduce the traffic coming and going, or staff rotations. There was no serious review of telework, for desk-based and support staff so that those essential services could be provided remotely from a safe distance. I reached out to local Marin County Public Health to share my concerns. They did make recommendations, but I learned that they have no jurisdiction over the state facilities, and their recommendations and feedback were mostly ignored by San Quentin Healthcare. So there was this missed opportunity for the ounce of prevention. And so that didn't happen, but the pounds of cure did happen as all hell broke loose when a large group of inmates, many COVID positive, transferred from another prison to San Quentin without proper testing or isolation. Coronavirus rapidly spread, resulting in thousands of staff and inmate infections, dozens of hospitalizations and intubations, and 28 deaths. This is at one prison. Statewide, there were tens of thousands of infections and hundreds of deaths. There were contracted medical staff flown in at great expense to manage the sick and recovering patients. The workplace safety violations that led to this crisis eventually resulted in a $421,000 fine, Cal OSHA's largest single penalty. But it's important to note that healthcare leadership at San Quentin includes a CEO of healthcare, chief medical executive, chief physician and surgeon, chief nurse executive, chief support officer, and at the state level, there's a federal receiver, deputy directors, regional directors, public health and infection control directors, and nobody from that list of leaders intervened at any step prior to this crisis. And ultimately, nobody was held accountable or took responsibility despite hearings and fines. Of note, the fine, there were other fines besides the $400,000 fine, but that's paid for by taxpayers. So there were really no consequences to the powers that be and the people in charge. So here we are, fall of 2023, RSV, norovirus, influenza, COVID is alive and well. And were any lessons learned? Are they actively doing anything to prevent this type of thing happening again? Are there universal masking in clinics? No, there is PPE access and they do fit testing, but there's no real ongoing education and postering, as MJ mentioned, installation of UV lighting, improved ventilation, no indications of, and this is a very old facility. And even in the new building, the health services building where I worked, my office had a window that didn't open and shared ventilation with the whole building, including 50 inpatient beds. So that has never really been looked at with any real scrutiny. And again, no real plans to control the flow of people. I think it's really important to think of telework and staffing issues as safety. You know, people think of telework, oh, it's so convenient, but it's a huge safety advantage to minimize to and from. So in conclusion, and there were actually hearings, the Little Hoover Commission, which is a instructive commission for the state of California, had hearings in 2020 on transitioning state government workforce to permanent remote work. Recommendations largely ignored, still ignored. So the bottom line is with corrections, they're always reactive and never proactive. And follow through is based on the subjective discretion, the whims of each department, ultimately enabling the management to abandon common sense, evidence-based practice, and any concern for the always vulnerable inmates and high-risk inmates, employees, and with no regard for community safety and not insignificantly taxpayer dollars. So thanks for letting me speak.
Thank you very much, Rita. Our next presentation is Fiona Garza-Tulip, who's a patient advocate.
Hi, everyone. Good afternoon. My name is Fiona, and today I want to share with you the story of my mom, Isabel Odette Hilton Papademetrio. She was a 64-year-old respiratory therapist in Dallas, Texas, who lost her life to COVID-19 on July 4th, 2020. See if I can see myself. Okay. My mom was in the business of helping people breathe, yet ironically, it was her breath that was taken away, all due to lack of proper infection control measures at her workplace. Despite working in a rehab unit, HIPAA laws prevented her from knowing if her patients were COVID positive. She probably performed breathing techniques with patients who were COVID positive, all without knowing. And also, to add to that, her hospital didn't offer training or adequate PPE. In fact, the PPE that she was using were expired surgical masks, very much like the ones that, I buy off of Amazon in bulk. And she had to turn them in at the end of each shift. So her hospital didn't offer adequate training, didn't have the N91 masks. And when she started feeling COVID symptoms, they couldn't give her a COVID test. They asked her to find it somewhere else. They took her temperature, said to drink lots of fluids. So she spent 2 excruciating days while already fatigued from the virus to find a testing center. We all thought it was a mild case until it was too late. My mom was a meticulous person. She documented her symptoms, her fever, her food intake, all in a notebook. But what she couldn't document was her fear and her struggle and the profound impact her loss would have on her family. We thought she'd pull through, and she even texted me to assure me that she'd be there for her only grandchild, my daughter, Lua. But in the span of 1 week, we lost her. And unfortunately, some of her colleagues were at the hospital, former colleagues were at the hospital trying to save her, but she died pretty quickly. You might wonder why I'm sharing the story, and it's because we need a change, a systemic change in how healthcare facilities manage infection control. Lives are at stake. My mom's life was at stake, and she was let down. She trusted the very hospital that didn't protect her. My mom was a very energetic person, full of life, full of love, especially for my daughter. And even after her passing, we received a pair of pink frilly sandals she had ordered for Lua. That was my mom. She was always thinking of others, even in her last days. So I urge everyone, let's not make the same mistake twice. Let's prioritize education, training, and resources for healthcare workers who are the backbone of our healthcare system. And let's ensure that no other family has to go through what mine did. Thank you for listening.
Thank you, Fiona, for sharing your story. And finally is Matt Calzia, a registered nurse with the Oregon Nurses Association.
Thank you. That was a tough story to hear. I appreciate you sharing that, Fiona. My name is Matt Calzia, and I'm the Director of Nursing Practice and Professional Development at the Oregon Nurses Association. We represent about 15,000 registered nurses. And I've been a nurse in Oregon for 12 years, and I do continue to provide direct patient care at a local hospital. During the peak of the pandemic, I sat on an Oregon OSHA Rules Advisory Committee as we established an emergency COVID-19 temporary standard. And my experience working with and listening to the hospital lobbyists and those who wanted to minimize regulations was simply that hospitals want the least amount of regulations possible. And it does not necessarily need to be evidence-based. And they want to be able to operate by meeting the most minimum standards possible at the expense of their healthcare workers. Frontline healthcare workers were wronged by their government agencies and their employers during this pandemic, and they continue to be wronged. We were frequently told there was no aerosol transmission in the beginning, and we on the front lines were concerned that that was not true, and we felt that we needed an abundance of caution and precaution while the science catches up. When it was acknowledged that aerosol transmission occurs, there was inadequate PPE available to protect healthcare workers, and we began engaging in the risky practices of reuse and reprocessing of PPE. And then when we went out and we found our own elastomeric masks, we were told by our employers that we would face discipline if we were to bring those into our care environments. And many of these in emergency departments and other areas where we know that there was a lot of transmission occurring. In recent months in Oregon, we have seen entire operating room departments shut down because of staff infections of COVID as hospitals try to find the least amount that they can do to protect their staff members. And when these outbreaks occur in hospitals and other care environments, we exacerbate a backlog of care that is needed to be delivered to our communities. And it just continues the problems that we see of people's chronic illnesses being compounded and more complicated because of delays in care. Nurses and frontline healthcare workers need the CDC's Healthcare Infection Control and Advisory Committee to operate in transparency and to include the voices of frontline healthcare workers over the desires of healthcare executives. The reality is this pandemic eroded trust in that agency, in the CDC, because it was of inadequate and inconsistent response. And the only way to reestablish that trust is to do it with evidence-based guidelines that provide an abundance of protection for workers, not loopholes for employers. I appreciate everybody's time and comments today and for allowing me to participate.
Thanks so much, Matt. So this is Jane Thomason. I'm gonna jump in here because I want to kind of wrap things up and say a big thank you to everyone who sent in your recommendations via the link that we've been sharing throughout the webinar. I'm going to share my screen. I've been reading what you guys have been sending us. So our plan is to take these recommendations, to take all of the information that we heard from the speakers in today's webinar and send it to the CDC, send it to the HCPAC members, send it to the staff at the CDC who are supporting HCPAC in this process to make these guidance updates. So you can see I've put together some of the main things that we've heard from you all in this webinar. We've heard that you are recommending the CDC correct the false dichotomy of near droplet versus far airborne. You have emphasized the importance of a multimodal infection control strategy that incorporates all of the different controls that we've heard about today and doesn't just focus on one, doesn't just race to PPE and forget about the others. You all talked about the importance of patient screening and isolation, about transparency about exposures. There were many comments about the importance of having explicit standards for high quality ventilation and indoor air quality, and even having transparency so that patients and workers know what the ventilation and filtration rates are when they enter healthcare facilities or when they're waiting in a waiting room. You talked about universal N95 use, the importance of N95 respirators and other accommodations for high risk patients. You also identified the importance of tracking nosocomial infections, healthcare associated infections, which doesn't happen super reliably right now. There were a lot of comments about needing more collaboration with OSHA. I think that's one of the themes that we've heard throughout the webinar today. And in particular, a couple of folks called out the CalOSHA Aerosol Transmissible Diseases Standard as a model that CDC and HCPAC could and should be following, particularly on elements where, like the CalOSHA ATD standard requires respirators for all novel pathogens, not just those that are in, quote, pandemic phase like the CDC is proposing to do. You called out the importance of precautionary principles and some other important pieces around public input here. So we're going to take all of these recommendations. You still have the opportunity to provide your thoughts. If you're one of those people who's still formulating, you wanted to hear what everyone had to say, you're still formulating your thoughts. I know I'm often one of those in that camp. You still have the opportunity. The link will be open for the next couple of days. So if you wake up in the middle of the night on Saturday night and you're like, oh my gosh, the CDC needs to hear this thing, you can still send it to us. We'll be collecting all of this and sending a report to the CDC in the coming days. That report will be available on the website, the workshop website so that you all can reference it and share it where you would like to share. Lisa, is there anything else you would like me to cover before I turn it over to you?
Can't think of anything. Thank you very much, Jane. That was a yeoman's job in terms of pulling all those recommendations together into a summary slide. And those will be very helpful to us. So I'm going to just express my thanks again very much to, especially to Mitch Rosen and his team. His IT team, Raymond Klinkstale and Shiloh, who helped us keep this all on track and did some troubleshooting with various people behind the scenes. I'd like to thank Bill Sawyer, Laura Warren, and all the Rutgers IT team. And really, I can't express my gratitude enough to Mitch, who, as I said, did this all in less than a month, and always with a great amount of humor and almost immediate response whenever we asked him to do something. This workshop would not have been possible without the very hard work of my planning team as well, including Peg Seminario, Jane Thomason, Jonathan Rosen, Deborah Gold, Barbara Materna, Kate McFall, and Kathleen Harriman. I'd like to thank all of our presenters for agreeing to participate, again, pretty much at the last minute, to our stakeholder speakers for sharing your very powerful and personal stories, and to the moderators, Kate McFall and David Michaels, for helping us answer participants' questions. And thank you most of all to all of you who participated in this workshop. I hope we can continue to work together for better patient and worker safety in healthcare. Thank you.
All right, thank you everybody for participating. Thank you to our speakers. This concludes our webinar. Have a great weekend, everybody.